health camps, and digital outreach, we have touched millions of lives with awareness, knowledge, and hope. Countless students and community members have gained the tools to build healthier habits, make informed choices, and carry those lessons into their homes. The future of India.
Ladies and gentlemen, our esteemed dignitaries have joined us inside the hall. We'll begin the conference on an auspicious note with the lamp lighting ceremony. May I request our esteemed dignitaries to kindly proceed for the lamp lighting ceremony. Requesting Mr. Rajesh Bhushan, Dr. Sunila Garg, Mr. Anil Rajput, Dr. Asha H., Dr. R.S. Mishra and Dr. Anil Agarwal to kindly proceed for the lamp lighting ceremony. A round of applause as we light the ceremonial lamp. We thank our distinguished dignitaries for lighting the ceremonial lamp, and with this we officially have inaugurated the Illness to Wellness second conference. And I'll now take this opportunity to invite our distinguished dignitaries on stage. Ladies and gentlemen, please join me in welcoming on stage Mr. Rajesh Bhushan, former Secretary, Ministry of Health and Family Welfare, Chairperson, Governing Council, Illness to Wellness Foundation. Can we give him a more energetic round of applause? A very warm welcome to you, sir. Joining him on the dais, we have with us Dr. Sunila Garg, member FICCI Swasth Bharat Task Force, Professor Emeritus, National Academy of Medical Sciences, ex-Sub-Dean and Head Department of Community Medicine, MAMC. Kindly keep the applause going. Mr. Anil Rajput, Chairperson, Advisory Council, Illness to Wellness Foundation. Dr. Asha Hegde, Director, South Asia, HIV, Hepatitis, STIs and Family Health Path, India. Kindly keep the applause going as we welcome our esteemed dignitaries on stage. Dr. R.S. Mishra, Principal Director and Head Internal Medicine and Co-Chair of Academics, Max Smart Super Speciality Hospital, Saket. Dr. Anil Agarwal, Co-Chairman, Institute of Surgical Gastroenterology, GI and HPB Oncosurgery and Liver Transplantation, Sir Gangaram Hospital, and member Advisory Council, Illness to Wellness Foundation. Once again, a very warm and hearty welcome to all our distinguished dignitaries. Your presence truly elevates the significance of this insightful conference. And now, as a token of appreciation and as a gesture of warmth, we'll be welcoming our distinguished dignitaries by presenting floral bouquets. May I request Mr. Anil Rajput to kindly felicitate our esteemed dignitaries. We begin with Mr. Rajesh Bhushan. Once again, a very warm welcome to you, sir. We now welcome Dr. Sunila Garg. Kindly keep the applause going. Dr. Sunila Garg. A very warm welcome to you, ma'am. Dr. Asha Hegde. A hearty welcome to you, ma'am. Dr. R.S. Mishra. A very warm welcome to you, sir. Dr. Anil Agarwal. A very hearty welcome to you, sir. We once again thank our esteemed dignitaries for their gracious presence. distinguished dignitaries, delegates, ladies and gentlemen, a very warm welcome to all to Illness to Wellness second conference on prevention, diagnosis and treatment for hepatitis on the occasion of World Hepatitis Day. As some of the brightest minds in healthcare policy and public health come together under one roof, today's deliberations will focus on transforming knowledge into action, strengthening partnerships, and advancing India's commitment to a hepatitis-free future. Once again, thank you all for joining us for this important initiative, and we look forward to an insightful and impactful morning. To set the context for today's conference, it is my privilege to invite Mr. Anil Rajput, Chairperson, Advisory Council, Illness to Wellness Foundation, to deliver the welcome address. Can we all please welcome him on the dais?
Mr. Rajesh Bhushan, former Secretary, Ministry of Health and Family Welfare, and Chairperson, Illness to Wellness Foundation. Dr. Sareen is going to be joining us online, who's Senior Professor, Department of Hepatology and Director, Institute of Liver and Biliary Sciences, New Delhi, and member of Advisory Council, Illness to Wellness Foundation. Dr. R.S. Mishra, Principal Director and Head, Internal Medicine, Max Smart Super Specialty Hospital, Saket. Dr. Asha Agde, Director, South Asia, HIV, Hepatitis and Family Health, PATH India. Dr. Anil Agarwal, Co-Chair of Institute of Surgical Gastroenterology, Sir Gangaram Hospital, and member Advisory Council, Illness to Wellness Foundation. Dr. Sunila Garg, member FICCI Swasth Bharat Task Force. Good morning. It is my privilege to welcome you all today who've come together to observe World Hepatitis Day, a day that reminds us that some of the greatest threats to health are often the least visible. Hepatitis is one such silent disease. It progresses quietly, often without symptoms, yet can ultimately lead to cirrhosis, liver failure, and liver cancer if left undetected. The numbers are sobering. The World Health Hepatitis Report 2026 estimates that more than 1.3 million people died globally from viral hepatitis in 2024, with hepatitis B and C accounting for over 95% of these deaths. India carries a significant share of this burden. According to this report, India is amongst the top 10 countries, amounting to nearly 69% of global hepatitis B related deaths, with an estimate of 40 million people living with chronic hepatitis B infection. These figures underscore the urgent need for greater awareness, timely screening, and early intervention. Yet, amidst these challenges lies a powerful message of hope. The liver is one of the most extraordinary organ in human body, with remarkable ability to regenerate itself. But this resilience has its own limits. Recovery is possible only when disease is detected early and further damage is prevented. Once extensive scarring occurs, the opportunity to regenerate diminishes. Hepatitis, therefore, reinforces one of the most fundamental truths of healthcare. Prevention and early detection are far more effective than late intervention. More than 2 millennia ago, Acharya Chakra articulated a principle that modern public health continues to reaffirm. Preventive health is higher calling than merely treating disease. As the Chakra Samhita reminds us, it is more important to prevent the occurrence of disease than to seek a cure. As the Illness to Wellness Foundation continues to believe and propagate this philosophy, which defines our mission, we believe healthcare must evolve from reactive treatment to proactive prevention, from illness management to wellness promotion. This encourages reality that is, hepatitis is amongst the few major diseases for which we already possess almost every tool required to defeat it. We have effective vaccine, reliable screening methods, curative therapies, and proven public health interventions. The challenge before us is no longer scientific. It is one of awareness, accessibility, affordability, and collective action. International experience shows that determined action can achieve this very, very successfully. Egypt transformed one of the world's heaviest hepatitis C burden through a nationwide campaign that tested more than 60 million people and connected those diagnosed to treatment, achieving cure rate about 98%. Georgia combined large-scale screening with referral treatment systems, screening more than 2.8 million people and treating over 80,000. The Maldives, despite its dispersed island geography, became the first country validated by the World Health Organization for eliminating mother-to-child transmission of HIV, hepatitis B together. Having said that, India has made significant progress as well. Through the National Viral Hepatitis Control Program, launched under the Ministry of Health and Family Welfare, by integrating hepatitis with the National Health Mission, the program is expanding testing, ensuring free treatment, and strengthening prevention efforts across districts, hospitals, and primary healthcare centers. I am of the firm opinion that success demands a whole of society approach. Government, healthcare professionals, researchers, industry, civil society, the media, and citizens all have vital role to play. Public health succeeds not through isolated efforts, but through partnerships that place prevention at the heart of national development. The Illness to Wellness Foundation remains committed to advancing this movement through awareness, evidence-based dialogue, policy advocacy, and collaborative action. Our aspiration is simple, yet ambitious: to make wellness the first line of defense and prevention the first principle of healthcare. I'm confident that today's deliberation, led by our distinguished experts, will deepen our understanding of hepatitis and inspire practical solutions that accelerate India's journey towards its elimination. On the World Hepatitis Day, let us renew our collective resolve to screen early, vaccinate wherever possible, eliminate stigma, expand access to treatment, and ensure that every individual has the opportunity to live a healthier and fuller life. Friends, as India advances towards the vision of Viksit Bharat, we must also strive for Swasth Bharat. No nation can fully realize its demographic and economic potential if preventable diseases continue to diminish the health and productivity of its people. Health is not merely a social imperative. It is an economic asset, a developmental priority, and national responsibility. On this note, I extend my sincere gratitude to all our eminent speakers, partners, and participants for joining us today. I wish this conference every success and look forward to a meaningful and enriching discussion. Thank you, and Jai Hind.
Thank you very much, sir, for setting the tone for today's deliberations. Ladies and gentlemen, we now request you to direct your attention towards the screen for a special address by Padma Bhushan Dr. Professor S.K. Sareen, Senior Professor, Department of Hepatology and Director, Institute of Liver and Biliary Sciences, New Delhi, and Member Advisory Council, Illness to Wellness Foundation. Sir, over to you. A very warm welcome to you, sir.
Hepatitis as one of its purposeful goals. I was very impressed hearing you, sir, that how you would like to partner, collaborate, and include everyone into this mission. 28 July was chosen because it happens to be the birthday of a member who had discovered hepatitis B. So in the memory of this great scientist, we all would like to commit ourselves to this. I also see that in your mission, you have mentioned prevention, diagnosis, and treatment. And where are we? And I see so many distinguished speakers after me, so I very briefly touch on prevention. Delhi in 2001, in the presence of the Honorable then Chief Minister, was the first city, first state to launch the Universal Hepatitis B vaccination program, 2001. And it led to Sikkim and many other states. And finally in 2002, we were able to convince the then Prime Minister, Shri Atal Bihari, that it should become a national program. So prevention started from Delhi, 2001, universal vaccination. And India has made substantial progress, at least the birth dose. Within 24 hours of birth, India has done reasonably well. The first dose, that is at 6 weeks. However, the second, third, fourth doses are not so compliantly taken by mothers and the kids. So we need, and I would like you to have, whenever you have this conversation with Gandhi and ops and the pediatric people, that the third, fourth doses of hepatitis B vaccine are as important. The second part of prevention is for all of us. Daily, we did a survey. Out of 100, 93.4%, this survey was about 7,000 people, 93.4% of adults have not taken hepatitis B vaccine. Can you believe it? Only 4% of the total survey had taken the vaccine, all 3 dosages. And this is the capital of the country. So, people think that hepatitis B vaccine is only meant for children, for newborns. No, it is for all of us. Any one of us at any time might need a surgery, blood transfusion, or any other intervention. Then you don't run for getting the hepatitis B protection care. So my request is, we need to make a movement, educate, and I would like everyone listening here right now in the hall to please raise hands if you can. I would get vaccinated. Please. I would be very impressed. Can you show the camera for the audience? Everyone, if you have not got vaccine, please get vaccinated. It is less than the cost of your going for a coffee, not for dinner or so. So we have started this movement. The third point, I would like the corporates, which you represent so well, that every corporate can say, oh, we are 5-star. Everybody in our company, organization has been immunized. There is a difference between vaccination and immunization. You take a shot, but you never make antibodies. My request is, starting from IPC, all other organizations in SOCM, that you can say, when we meet next year, 2027 or 28 July function, you can say, well, we are 90% of us, our employees, are immunized. Immunized means they have put antibodies. This will also give a message to their families. So let's make a movement of corporates. Let's make a movement of companies where everyone is immunized against hepatitis B. No one wants COVID. No one wants flu or influenza. But do you want hepatitis B? No. So that is the second step I would like we should take. The point in prevention actually clubs hands with diagnosis. Diagnosis is very difficult. Can you hear me please? Or yeah, diagnosis. I think the internet is lost. Can you hear me, sir? Yes. Okay. So the diagnosis depends upon what Rajput sir said is about a stigma or marginalization. Now, in a family, if there is somebody who has hepatitis B, he is considered outcast. They think that this man has done something wrong because they club hepatitis B with HIV, which is not correct. Hepatitis B, 95% comes from mother to baby. And the person, let's say it's a 10-year, 20-year-old man who has been tested, or a young lady going for pregnancy testing is tested positive. This lady has not done anything wrong. She got it from her mother, who got it from her mother. So the mother-baby transmission is the most important part. But the society considers those who are positive as outcasts, which is totally wrong. Don't stigmatize, marginalize, or isolate them. It is not their fault. They could choose their mother and got the virus. So my second part in prevention and diagnosis is club. People will not come for testing unless we give them open arm welcome. Otherwise, they will feel threatened. या मेरी नौकरी चली जाएगी, मेरे को डॉक्टरी नहीं मिलेगी, मैं सर्जरी नहीं कर सकता. Anil is sitting there who witness to this that many people, nurses, technicians, doctors have been actually banned from doing invasive procedures. So diagnosis will need commitment from the society to people to come out. The tests are easy. The second part would be the new way WHO plans. If you have tested positive hepatitis B, then do a reflex testing by doing a DNA. Normally, we will do hepatitis B, inform the patient and then get it. Reflex testing means the labs do the DNA testing, then is there. Once the DNA is positive, we can see if this guy needs treatment or should be treated. So diagnosis will require all family members, because if mother has given birth to 3 children, maybe 2 out of 3 are positive. So the family members, those who go for repeated dialysis, blood transfusion, thalassaemics or hemophilics and others, diabetics, they all require to be tested, vaccinated and immunized. The important part is linking to treatment. And linking to treatment will require a change in mindset. So your third message, sir, was about the progress in treatment. I would say we, the doctors, were the biggest culprits in not letting people be treated and waiting till the time the patient, the infected guy, becomes serious enough. Till the time the disease is evident, like he has high viral load, he has got inflammation in the form of high ALT, or he has got adequate fibrosis of the liver. So we were gatekeepers of making a patient worse rather than making a patient get better. Fortunately, with all our efforts in Asia across 81 countries, the new guidelines released in 2026 June have changed this concept of treat select to treat all. Meaning thereby, now you just need a hepatitis B test and a DNA test. Don't need to wait whether the fibrosis, advanced scarring, as Rajput said, has developed or not. So treat all. And the National Viral Hepatitis Control Program needs to modify itself. China has modified to a very large extent. We need to modify, and Rajesh ji is here, who has immense contribution to the national health programs and policies. He can influence that. Yes, we have the largest program, but we treat out of 35 million, less than 1 million people. We need to reach out, and the WHO goal of treating 80% of the infected can be reached maybe not in 2030, but maybe 2033 or so. 5 years from now, let's pack our bags and start moving to treat all. My last 2 points are about hepatitis A and E. Hepatitis A is a different virus, generally used to occur in children, and one child in the family, and the second one will also get it young enough and they will get better. And nobody would know, like cough and cold and pneumonia or flu, the child will get better, lose appetite for a day or 2, 3, and then it is back to work, back to school. Now we are seeing, I must say last 5 years, hepatitis A occurring in adults, 20 to 40 years of age. These are very serious infections in adults. If it occurs in 5 to 10 years, then okay. But 20 years onwards, hepatitis A is lethal. And acute liver failure, yesterday and today, between one night, 2 patients have already come. And I am pained because these people were from rich society, those who could afford. So once you afford, you have a hygiene theory. बच्चे ने कभी बाहर गंदा पानी नहीं पिया, खाना नहीं खाया, उसको कभी हेपेटाइटिस ए और ई जो कि फूड से, वाटर से होते हैं, उसे कभी हुआ ही नहीं. And now he gets a hepatitis A when he is 20 plus. This guy is going to have severe infection. And India now, 60% has immunity against hepatitis A. Earlier it was 90%, now it is 60%. So 40% of the people are vulnerable to hepatitis A, and in adulthood, in diabetics, in obesity, alcohol, and others, this can be fatal. So there is a vaccine available. We need to move towards a national thinking. Who should get hepatitis A? And I strongly would recommend preventing these hepatitis A infection by giving vaccination for chosen, especially those who are affordable and can afford. Similarly, hepatitis E, which is very common as an epidemic during rainy season, I would like people to wash hands to understand the washing hand techniques are also not known, and food is kept outside. Hepatitis C vaccine is also getting available for some time in India. With this, I would like to say the WHO message is break it down. Break it down now. Make yourself accountable. Take a pledge that yes, hepatitis has to be stopped by me. Me means whether you are a doctor, you are a nurse, public health specialist, and we need to see that, okay, here our progress we have made. And I want to salute Illness to Wellness Foundation and all the other people whom you have very rightly, very appropriately brought here to take this message. I am immunized, my company is immunized, I will not in any way marginalize or stigmatize people with hepatitis B. And of course, I will also give this message to 10 more people. Thank you, sir, for inviting me and including me in your program.
Thank you very much, sir, for your enlightening and inspiring message. Thank you so much for joining us virtually. Moving forward, ladies and gentlemen, it is now my privilege to invite Dr. R.S. Mishra, Principal Director and Head, Internal Medicine, and Co-Chair of Academics, Max Smart Super Specialty Hospital, Saket, to deliver the special address. Can you please welcome him on the dais?
A very good morning to everyone who are present here. It's a great honor to be here this morning with everybody. I would like to sincerely thank all the organizers, Illness to Wellness Foundation, for organizing this wonderful program and inviting me to be here and discuss my thoughts about the hepatitis. So, ladies and gentlemen, if you look at the history of hepatitis, it's as old as medicine. And Hippocrates, in his writings, he's mentioned about jaundice about 2,500 years ago. And since then, for centuries, it was not known why this jaundice is happening. Only in 20th century, we came to know that jaundice was not a disease. It was basically a symptom, and it was caused by the group of disorders. And then the hepatitis was basically, 20th century, we came to know that hepatitis was also not a single disease. It was basically caused by at least 5 viruses, different viruses. They have different characteristics. And depending on that, you can diagnose, prevent, and treat as well as this. So today's World Hepatitis Day, as Dr. Sareen said, let's break it down. Break it down is like a disease which is easily preventable, easily diagnosable, and easily treatable. But unfortunately, we are still sitting here with millions of people having hepatitis B and not able to do it. Why? Why? Because there are many barriers which we need to break. And that's why the theme is let's break it down. Now, I'll go through in next 5-7 minutes to, just introducing, because hepatitis is a big science. There are big books available, postgraduate students, they read. I'll just introduce what the hepatitis and what we need to do and where we are at the moment today. The biggest irony about hepatitis is that still we are living with the hepatitis, despite that we have a great knowledge, great advancement in the science. We have a very good vaccine, which Dr. Sareen was saying, hepatitis B, one of the best vaccine invented on this earth, very safe and very, very effective. But the coverage rate, you heard what Dr. Sareen said, is hardly 5 to 7% in our country. And it's easily diagnosable. We have very good tests by which we can diagnose hepatitis very easily, and it is highly preventable by giving vaccines and very effectively treatable. Hepatitis C can be cured now with simple giving some pills for few weeks. Hepatitis B can be totally controlled, and you can prevent those chronic complications which happen because of this. So why, if you look at, despite all this, why there are 300 million people living with hepatitis today? And 1.3 million die every year. As Dr. Rajput also mentioned that in 24 data says this is what it is as of now, despite a lot of efforts being made. So the answer lies in the lower box, which I think is not projected here, but let me tell you, there are many barriers in hepatitis, why we are at this moment, the situation we are facing. Very low awareness about the hepatitis. People do not know what hepatitis is, how it is spreaded, what they are supposed to do. Until you have this awareness increased, it is very difficult to break this, the hepatitis. And it's a silent progression. When hepatitis virus enters into somebody's body, it silently enters, patient will not come to know, it will not give any illness, and it will living there and proliferating, replicating, and causing low-grade inflammation in the liver, and ultimately damaging the liver over a period of, in 10 years, 20 years, and 40 years, simply living there, not giving any symptoms. That's the biggest barrier, and we need to break it, because we have to come forward, diagnose it early as possible, and there are methods to catch hold of those people who are at high risk of developing hepatitis B. Then there's a delayed diagnosis. Delayed is because people don't come forward because they don't know. It's basically not negligence, it's unawareness regarding hepatitis. There's still stigma attached to the hepatitis. And there's, unfortunately, in our country, there's unequal access to the medical health care, because we have a rural India, we have the urban India, and because of that divide, urban, like cities like Delhi, you have all medical facilities available, but if you go deep into the villages, hardly any facilities available, and that's the unfortunate part, but anyway, it's going to take time to get those medical facilities available for them, and this missed vaccination. So these are few barriers which we need to break, and that is why the theme is there. And no one should die from this preventable disease, which is diagnosable and treatable. That should be the main aim for next few years for us. Look at the Indian data, about more than 250 million people living with hepatitis B, another 50 million with hepatitis C. And 80% of these people are undiagnosed. So only 20% who are diagnosed, you can do something about it. You can treat them, you can prevent future complications. But what about those 80% who are living with viruses in their body and ready to spread and give it to other people? And that is what, and slowly this, the ultimate complications, what happens over a period of time is they develop stiff liver, that is fibrosis and leading to cirrhosis, hepatocellular carcinoma, that is liver cancer, liver failure, and those things happen. So what WHO has very ambitious, the program that in 2030 we should be able to eradicate, but this at the moment in 2026 looks very, for me, looks difficult. They have to extend the date, but it is doable, maybe in next few years. They have a goal of preventing 90% of, reducing the new infections, and at least 65% reduction in the hepatitis-related complications through this. As far as India is concerned, as Dr. Sareen said, we are one of the biggest hub of, reservoir of these viruses. 40 million hepatitis B infection, at least 10 million hepatitis C, and unfortunately, we also have hepatitis A and E happening, and each year during this monsoon weather, we keep getting these infections. And that is all because of the poor sanitation, poor hand hygiene, the water, the safe drinking water is not available to everyone, and that is what all leading is. So looking at this, and again, the challenges in our country is also the same. Low awareness, late diagnosis. The adult vaccination program is non-existent in our country, unfortunately, though we have many vaccines, including the hepatitis, but everybody thinks that vaccines are made only for children, because that's a very successful program, and if child is born, taking him to the vaccination center is an event for everyone, but when it comes to the adult, nobody thinks about that vaccination should be taken. That's a very unfortunate part, but we need to spread the awareness, rural disparity, and all these others. So looking at these challenges, government has already initiated a program, the prevention program, which was launched in 2018, and goal is, as it is stated by WHO, eliminate hepatitis by 2030. But unfortunately, when our country launched this program, 1 or 1.5 years later, COVID came, everything got disrupted. 2-3 years, there was no progress was made. But now in the last 2 years, I think they started making progress, and I'm hoping that in the next, few years, so they will be able to catch up what they have lost this period because of this COVID. Now, understand these 5 strains, they are different viruses, they spread differently, they can be prevented by different measures. So I'll quickly go through why hepatitis A is fecal-oral route. It is transmitted by, you having some contaminated food. There's no chronicity to this. That is one good thing is that. But now, as Dr. Sareen said, the adult are being infected with hepatitis A, that's very threatening. And the fortunate thing and good thing is that we have a very good hepatitis A vaccine available in all over the world. If everybody takes this, we can eradicate this disease, hepatitis A. B is spreaded by many means, like blood exposure, sexual transmission, perinatal. Perinatal is the most important because the large, if a lady has hepatitis B, which is silent, if she gives birth to 3 children, there's 90% chance that all 3 children will have hepatitis B, and that is the silent, spreading of infection all the body. And China has faced this problem. I'll come to that, the success story of China and Egypt later on in my discussion. Hepatitis C is only blood. Hepatitis D is a defective virus which can survive only if somebody has an hepatitis B. HEV, that is hepatitis E virus, is also a fecal-oral route spread. Fortunately, it is dangerous. If it happens to a pregnant lady, it can be fatal. But this chronicity is not there. Supportive care improves these patients. But at the moment, we don't have vaccine, but it is going to come, as Dr. Sareen has mentioned, that vaccine is going to come for this also. If you look at the spread, transmission, how it happens, there are only 2 ways it can spread. One, hepatitis is through the fecal-oral route, it goes through the mouth. Second is the parental transmission. And if you target these two transmission routes, you can definitely bring down the incidence. And interventions are, the vaccination, safe injection practice, then rigorous blood safety, because now we have achieved that blood banks are not there, the professional donors are not there, so each and every blood who's being donated has to be screened for all these diseases before it is transfused to the other person, so that you don't transmit the disease. Safe water and food and safe sexual practices should be done. So these are basically transmission-wise you can catch. I will talk a little bit about the silent progression. The first thing is that when virus enters into the body, it will not give any symptoms. It will remain there for decades. Chronic inflammation in the liver will be detected only if you're doing the liver function test. You will find increased SGOT, the ALT and AST. The only doctor can have suspicion this person may have an hepatitis B. It should be tested immediately. And then if you missed it, slowly the person is going to die, have fibrosis, and later on person will develop cirrhosis, and that is what we don't want in anybody developing, because that is something irreversible. Once a person develops cirrhosis, in future it's a death sentence unless you do the liver transplantation. And these people will only develop the liver carcinoma of the liver failure or ascites and those other things. So in this early catch is the biggest catch for us, or the medical professionals. Breaking the first barrier is the prevention. And in the prevention, there are 2 prevention: clinical prevention and environmental prevention I've already talked about. Universal vaccination, strict blood safety protocols, safe injection practices, hand hygiene, safe water, all those we know, but we need to implement. WHO has 4 strategic pillars: prevent, vaccinate, diagnose early, and treat. That is where we want to work at. This is basically a diagnostic funnel, which stepwise tells you what we need to do. So first step is risk assessment and screening. Now, country like India, you cannot screen each and every individual who are living in this country. So here we have to identify who are the people who are at high risk of developing hepatitis. And these are the first we should target are the pregnant ladies, because it is not that somebody is pregnant will develop hepatitis. Don't misunderstand this. They are the one who can spread infection to their next generation silently. And if you diagnose that lady, you're going to prevent the future generation in having hepatitis. Second is the blood donors. As I've already said, the safe blood donation. Healthcare workers are the another risk. High-risk people, because we are the one who are dealing with blood and their body, secretions. And each and every healthcare, it has become a necessity now that we all have to get vaccinated before when you join any hospital. And similarly, it is not only the hospital, anybody who's working in the health facility have to be vaccinated. This is how you catch hold of the people who are at high risk. Dialysis patients, because they are getting the dialyzed and they are, always with blood. HIV patients, people who inject drugs, they are like in Punjab. The Punjab has a very good model of, doing the prevention of hepatitis, because the drug use, IV drug use, people are at high risk, and they are the source of hepatitis B. Household contacts and high-risk individual, we have said. The next is to confirm the infection. The moment you have suspicion, low threshold has to be there to do the test. Like we in the hospital have, anybody who's undergoing surgery have to get hepatitis B and C check, and HIV. Why? Because here also we see so many. Person is absolutely normal, wants to get his gallbladder removed or appendectomy, do the test, you find that he's hepatitis B or C positive. You see, that's what the opportunity to test, and you got somebody who's, in future you can prevent the infection. Next is to assess the fibrosis, because the moment you diagnose, you need to know what the level of fibrosis is. There are many tests. The best is the fibroscan, which is a non-invasive test. It's like an ultrasound, and you can easily diagnose what level of damage has already been done by the virus. And from there, you can take on what kind of treatment a person needs. You can always decide. Then start treatment immediately, and depending on the algorithm, because we all have guidelines for any treatment. Similarly, the hepatitis also has a guideline, which patient, because it's going to be an individualized treatment again. One size fit all will not be possible. Everybody has a different level of viral load and fibrosis. You are going to decide which drug and how long the person is going to need. Hepatitis C is very easy. You give 12 weeks, patient will be cured. And the long-term follow-up. Once you successfully treat your patient, still you can't leave them alone, because even then they have some risk of developing, like hepatocellular carcinoma. That malignancy can happen later on in these patients. They are still at high risk, but risk has reduced significantly if you have picked them early and cured them from the hepatitis. These are the basically serological tests we do, very complicated. I will not go into the detail, but if you look at the hepatitis B virus panel, HPSAG is the first test we do. And it tells us if somebody is infected with hepatitis B virus. And in adults, if somebody gets hepatitis B infection, 90% of them, they get cured on their own. That's a good thing. So this HPSAG will be negative after 6 months. And 10% who are not going to get cured, they will remain positive for HPSAG. And those who become negative will have anti-HBs, the anti-surface antibodies, which you can see here. Then if you want, suppose somebody you have diagnosed and want to know when did he develop this infection, then we are supposed to do core virus IgM. Actually, it is very complicated. I'll not go into the detail. The HBE antigen is very important, because this is the test which determines whether the virus is replicating inside the body or not. And then you are supposed to catch hold and treat these patients so that, and it's highly infectious if this test is positive. And then of course DNA level and viral load. HCV is simple. There are 2 tests: anti-HCV to get to know, and then do the RNA test and you get to know the viral. And third very important test is the liver function. Once you diagnose the patient, do the liver function to determine what is the SGOT, SGTU level. If somebody has fibrosis and cirrhosis, then albumin will go down, because that is the synthetic function of the liver. So this is how basically mix and match of these tests we get to know what is to be done for your patient. Quickly, I've already mentioned that assess the damage, you need to do the viral load and then do the fibroscan, and you get to know what you need to do with your patient. For controlling hepatitis B, clinical reality is hepatitis B is not curable in every patient, but it is highly controllable. And what we need to do is that the goal is suppress the virus as much as possible. Bring down the viral level as low as possible with the medications. We have very good medications at the moment, that is tenofovir and entecavir. And the hepatologist will decide which drug is to be used in which patient. Now in future, we are going to get medicines probably like hepatitis C, where we will use and patient will be cured completely. So with this, if viral load has gone down, so I'll quickly go through this is what's a successful story. Very interesting. Egypt was known for all wrong regions in medical field. They had the highest possible hepatitis C virus in their country. And they didn't know what to do. All hospitals and clinics were overwhelmed with the hepatitis C patients with liver injury and cirrhosis and cellular carcinoma. And government was almost going to collapse. In 2018, they took this challenge and launched a program which is 100 Million Healthy Lives campaign. And what they decided that they are going to screen each and every individual who's ever 15 years of age. And that is also within 1 year. It's limited resources. They did it in 9 months. And they had no medicine to treat hepatitis C. It was costing $1,000 for them, for each patient. They brought it down to $60, and they started manufacturing in their own country. And 1 year, they screened 60 million people. They got 4 million positive patients, treated each and every patient. And strong database, and they tracked every patient who was diagnosed so that it was treated. And now look at the result here. Next, incidence came down, from 10% of the population coming down to less than 5%. And then they were awarded by WHO. That's the first award given to any country regarding this. It's a massive scale. They did not wait for the people to come to them to get diagnosed. They went to the establishments like schools, colleges, and offices, and caught hold of every citizen of that country. And that's the biggest example and eye-opener for them. And now this country is much better than any other country as far as hepatitis C is concerned. Now look at the China. I'm just quoting these two successful stories because we have all the facility, we have everything, we can do this. China in 1992 had the biggest burden of hepatitis B. 120 million people were living with hepatitis B. And that was a 10% population. So it was not possible for them to screen each and every person of China. What they did, they found that 95% of the infection was coming from mother giving infection to the child. So what they did, every lady who was pregnant was screened, diagnosed, treated, and the child born to those the pregnant ladies were also given human B immunoglobulins, which is a very expensive drug, and mother were treated in third trimester. Infection came down from 10% to 0.3%. Look at the data. What achievement they have had. So these are the two very important successful stories I wanted to quote. India, we know we can also do it if we have the will. We have all the infrastructure, we have all the resources. We can of course do it, and I'm sure we are going to do it. Thank you very much. I took too long, I think. Thank you so much.
Thank you very much, sir, for your knowledgeable presentation. With due respect, may I now invite Dr. Asha Hegde, Director, South Asia, HIV, Hepatitis, STIs, and Family Health, Path India. Ma'am.
Thank you. Good morning, everyone. Distinguished guest on the dais, my respect to Rajesh Bhushanji sir, Sunila Garg ma'am, Dr. Mishra, Dr. Agarwal, and Rajput sir, and the august audience present over here. It's a privilege to be a part of this conference on World Hepatitis Day and discuss one of the most important public health priorities, which is elimination of hepatitis. And when we speak about elimination, we know that elimination of vertical transmission is a low-hanging fruit that can be easily tackled. India is a signatory to triple elimination, HIV, hepatitis, and syphilis. And we know that of the three diseases, hepatitis becomes more important because 90% of the infection of hepatitis is through perinatal transmission. So it becomes a most important strategy for eliminating vertical transmission. Approximately 1 in every 60 pregnant women is HPS-AG positive, and 26% are HBe-AG positive, and we heard why it is so important, because it is high infectivity, while 1 in every 110 pregnant women is HCV positive. We also heard that there are remarkable advances in prevention, diagnosis, and treatment. So today, if an infant is positive for hepatitis, then it is something that we have missed. It's a missed opportunity. We failed to provide the hepatitis B birth dose to this child. We already possess the scientific knowledge, effective vaccines, accurate diagnosis, and highly effective antiviral therapies, as suggested by all the three speakers, Rajput sir, Mishra sir, Dr. Sareen. Everyone has said. So then what is the challenge? It's not that we know what to do, but I think the challenge is we don't know. Probably we should strengthen our implementation and say, how do we deliver this? How do we deliver these interventions consistently, equitably, and on a scale? And the answer again was given by Rajput sir. It is a collective action. So I just want to highlight 3 challenges that I feel in my experience that I've learned for elimination of vertical transmission. The first is siloed program delivery. So a pregnant woman, when she is screened positive for any of these diseases, so her main program is the RCH program, and from there, if she's positive for any of this, then she has to float around for all the 3 programs or whichever she's screened positive. Can a single window approach be done? Can we talk about integration following the 3 C's principle, which is coordination, co-location, and convergence? WHO has an integrated regional action plan for elimination of these 3 diseases, and we are, as PATH, we are supporting WHO in this activity. We know that in India, when a pregnant woman is detected, she goes for a delivery to her parents' place. So are we losing her in this siloed services when she goes from different facilities? Is this a missed opportunity that we are losing her? And how can we integrate these services through the different service points from the screen positive till the child is detected, maybe 2 years, the final diagnosis? We should also remember that elimination is not just about the mother and the child. It is also about the partner testing. It is also about the vaccination need of the family. So should it be a family-centered care that we should speak about? So that was about integration, which actually will help us improve coverage, reduce missed opportunity, optimize resources, and deliver better outcomes for mother and child. The second challenge could be the screening of mothers for the first screening of the mother for hepatitis or any of the other vertical transmission. So we know that RCH program screens them, but what is it that we can think about in today's day? Can we think about a multiplex test kits? And I just want to give an example of HIV and syphilis. We know that HIV screening of pregnant women is a very good indicator, but syphilis was not until 3 years ago. National programs introduced a simple dual test kit, and within 3 years, today syphilis is at par with HIV. Today syphilis testing rate for pregnant women is 95%. So can we think about a multiplex test kits that can be placed in a primary health center and a sub-center itself where every pregnant woman is screened for hepatitis? Also, the other thing for innovation is a self-test. Can we think about a self-test for a pregnant woman? We have already rolled out a hepatitis C self-test. A feasibility test was conducted by PATH. Today we talk about self-care. So when we talk about self-care of the women, self-test, and a digital tracking tool for the pregnant woman herself that Rajput sir spoke about awareness. So there is a patient app, there is a digital tracking tool. She can track her own services when she has to go. Under the self-care approach, if these 2 tools are there, this could actually build maternal agency. The third point in this challenge is data. When we talk about vertical transmission, we want to validate it. We want our country to be certified. And one of the 4 pillars in validation is data. It is data validation. So when we speak about data, and especially when we are talking about a longitudinal data for a period of nearly 3 years, how do we tackle this kind of a data in multiple vertical programs? Government of India has already got a solution for that, which is ABDM. Under the ABDM, that is Ayushman Bharat Digital Mission, using an ABA account, can we integrate all the program's data and we get a longitudinal record of the mother, and that would really help us when we talk about data validation and certification. In this, one more addition is the private sector. Government is also working with private sector under the ABA program, where private sector data gets integrated directly into the national program. Because one of the things when we talk about certification of elimination is the private sector data will be which is a very big challenge. Thailand could certify, the first country which certified is because their private sector data was less than 10%. And under the WHO rule, if it is 10%, they do not need to collect a private sector data. But in India, it is not so. We will need to have a private sector data when we talk about elimination, validation, and its certification. So as we gather today, let us reaffirm a shared commitment. Every pregnancy should be an opportunity to prevent hepatitis transmission. Every birth should be protected. Every mother should receive comprehensive care, and every child should have the opportunity to grow up free from hepatitis. I thank the organization, and I wish this conference every success in advancing knowledge, strengthening partnerships, and accelerating our collective journey towards a world free of viral hepatitis. In the end, I would like to speak 2 points, because this is about illness to wellness. So I was my personal story. I was detected with ovarian cancer 2 years ago. And then my message is that we should listen to our body. Before my diagnosis, 6 months before my diagnosis, I used to get very tired, extremely tired, but in my work, busy in my work, completely ignored this, completely ignored. I used to sleep at 6 o'clock in the evening and get up next day morning. And completely busy in my work, the thought of cancer never even entered my mind. It's only 6 months after my diagnosis when I looked back and I said, oh, my body was telling me something. And I think we are overlooking that. Our body always tells us something. There's something wrong in our body. It could have been a simple anemia, or it could have been a severe disease like cancer. But the point is your body is telling you something is wrong. And today's fast pace, we are just overlooking that. It could be any signal that your body is trying to give, which is not normal for yourself. That was my first message. My second message was, after my chemotherapy, after I ended my chemotherapy 1 year ago, I had severe neuropathy. I went into all kind of treatment, was not successful. In the end, I just stopped everything. I was dejected. I used to work from my bed. I used to lie down in the bed and work. But one day I pushed myself and went down for a walk. And that one day turned, today it is more than 6 months that I'm continuously exercising, and my pain is so much better. I'm able to live now. So my message was exercise, exercise, exercise. I think we are forgetting this. That habit should be inculcated for the children and should go on till the end of life. Exercise for a healthy life. Thank you.
Thank you very much, ma'am, for sharing your valuable perspectives with us, and especially your eye-opening and inspiring story. And now, ladies and gentlemen, marching ahead to provide a comprehensive overview of hepatitis, it is my pleasure to invite Dr. Anil Agarwal. Can we all please welcome him on the dais?
Good morning, everyone. And Anil Rajputji, dignitaries on the dais, off the dais, friends. It's an honor and a privilege to be here today in the Illness to Wellness program, very nicely curated by Anil Rajputji and his team on this occasion of this World Hepatitis Day. And I think you had a very nice overview about the medical aspects of hepatitis by the two speakers who very nicely, Dr. Mishra and Dr. Sareen. Dr. Sareen, who is, in fact, I would say the hepatitis man of India, because I think he started that hepatitis awareness program on 4th of December for our country, for our city. And so I think as a surgeon, I would probably stick to a little more surgical aspects of hepatitis related. And I spent so much time in the operating theater, often dealing with the consequences of the diseases that could have been prevented, detected earlier, or treated more effectively by much lesser morbid procedures. And hepatitis and its sequelae is one such disease burden which probably can be prevented and can be totally prevented. I mean, as you were taken through that there are 5 main types, and I think in this you have to keep in mind that all viruses, treatment or prevention actually first, because Sir Dr. Rajesh Bhushan as the Secretary Health, and in the last year also we had this discussion about the government need to focus on A and E, which is orophycal route, which is entirely preventable. Any developed country do not have this now. So I think, of course, in the magnitude varies. And as you have been already talked about, that it remains silent for a long time, till it damages the liver, causing fibrosis, cirrhosis, liver failure, and cancer, and by when the therapeutic window for simpler intervention has often passed. And therefore, patients and families who never knew that their loved ones had hepatitis until it was too late. And we know that prevention is far more powerful than any operation that can be performed for hepatitis-related ailments. And vaccination against hepatitis B is safe, effective, and widely available. Now here again for awareness, this has to be important. I would re-emphasize the point that Dr. Sareen made, that you get immunized, you get the jab, don't think that you are immunized. Madam will tell Dr. Sunila that it is important what's your titer, HBS antibody titer, and that is what are you effectively immunized against that disease. And of course, adopting the safe medical practices, proper sterilization and careful handling of blood and blood products have significantly reduced transmission risks in healthcare setting, but awareness outside the hospital is equally important. I think that is very, very important, and one of the important way how hepatitis is spreading, which could be unregulated tattooing and other body piercing and other these things that people are using. It is like any surgical intervention procedure. And so all testing, all precautions, universal precautions, etc., have to be taken. Even going to a barber, I think that, again, that is a thing which leads to spread of the disease, spread of hepatitis. And so that all contributes. So you have to, of course, we know about those who inject drugs. And so all these things, and early detection is another critical step, I think, because now the government has done, have brought about various schemes, and the very important is the prevention of in 2018 that it was addressed to that for hepatitis prevention and treatment. And for that, I think one has to take the help. Now the drugs are available, so I think free of cost to the people from all the government hospitals. And today, as has been again pointed out, that the treatment has advanced, like hepatitis B is preventable by immunization, hepatitis C now with the drug available and can be virtually cured. And so this can allow patients to live longer and a healthy life. But this is only possible if the test is done in time. And in testing, when we talk about, like it was alluded to, that vertical transmission. Now, in fact, what people tend to forget is that you need testing of the family members. Like if one child has got it, the other child in the family can get it. There could be a common source for other infections also. So I think it is important, and that is why in the prescription it is always one of the things that test for the family. Now this year's theme, WHO has been very timely giving these with that global goal of eradicating this as a health threat by 2030. Like very nicely in 2021, in the time of COVID, they said hepatitis cannot wait. One life, one liver. So this time also they have written that let's break it down, which aims at let us break down the barriers which exist so that we can effectively deal with hepatitis. And this could also be done that you could break down the barrier by also breaking down into various steps that need to be taken by individuals, by government and other people involved in the thing. You could be barrier of awareness, so people seeking testing early. And also here I would tell you that breaking the barrier of awareness, it is at all levels. Like, there are some physicians and surgeons in the audience, like he talked about hepatitis E antigen. Like people think that only doing hepatitis B antigen and antibody is enough. And you will have to take that risk of surgery. We know that if we treated hepatitis E antigen positive, which is more infective, and we get the HBV DNA and then treat them, you can bring down the infectivity of that disease. So I think that is important. In the healthcare workers, now there is more awareness to say that you do not keep it in the closed thing, depending on if they are likely to infect other individuals. Barrier of access, which in our country of this magnitude, and because when we talk about Hepatitis Day, I mean obviously we are focusing on hepatitis, but there are so many other health issues, problems. So probably that is again the government has to take into account that what all can be. And in this, one of the things that I would tell you, I had requested the Delhi government also at one point, Dr. Rajesh and Dr. Anil Rajput, that HIV, which has got a well-laid Madam Sunila knows about and talks about that, is the well-laid system. However, when you look at the infectivity or the transmission from the blood and blood products, HIV has got the least, right, as compared to hepatitis B and C. And I think because of compartmentalizing this, we are probably not focusing, and if we got that together and had a consolidated program to prevent this, these three viruses which create this havoc. So I think that is what is important. The barrier of stigma, I think Dr. Sareen in one of the I think maybe 3 years ago, in the hepatitis awareness program, he had talked about that we should destigmatize. They said that maybe it should be made, notifiable disease, but that, I mean, may have its own limitation, but stigmatize so that it should not be viewed as that somebody is hepatitis B or C positive, and so it is a kind of an outcast. And the barrier within the healthcare system, where late referrals limit outcomes. So that is very important, that you have to realize that till when it is under your realm of treatment and when you should refer it. And India, we know that this universal immunization program, which includes hepatitis B vaccination and this national viral hepatitis control program. Now here again, one thing I'll tell you, if you look at the statistics, within 24 hours, the figures are still wanting. We need to reach that. People would say that, oh, by the infant grows 1 year, it is 94% or even higher. But you have lost the time when you could prevent it. Because the vertical transmission, you need to immunize them within 24 hours of delivery. So the timing is very, very important. And if we succeed in strengthening vaccination, expanding screening, and ensuring access to antiviral therapy, we will not only reduce the surgical burden, but more importantly, we'll save millions of lives. And as clinicians, policymakers, and members of the community, we each have a role to play. Let us strengthen screening program, expand vaccination coverage, and ensure access to effective antiviral therapy. And let us work together, not just as doctors or patients, but as a community to eliminate viral hepatitis by 2030, the global goal of WHO. And ultimately, the goal is to shift the burden of hepatitis care from operating theater, as a surgeon I'm talking about, to outpatient clinics, from where complex surgery to early medical management. And hopefully, fewer people reach operating table because of this preventable disease, and hopefully hepatitis related surgery is eliminated from the surgeon's list, and hopefully even the surgeon is eliminated from the hepatitis program by year 2050, because we'll have to still treat the sequelae of hepatitis. So I think one message that I would like to give in the end for the individuals is the 3 gets. Get immunized, and which is not just get vaccinated, ensure that you're immunized. Get tested, because even though in the national health program, because of cost constraints, etc., it may not be included as overall for everyone, but as an individual, you should get tested so that you can test your families, you can take treatment on time. And get treatment. Do not ignore, because as has been highlighted, that this disease remains silent for a long time. And we are talking about illness to wellness, but hepatitis is one thing, why illness to occur? Prevent it, and so remain well, and that is what the motto would be. So thank you, Dr. Anil Rajput and your team. It has been wonderful year after year participating in your program, and we can see the zeal with which you carry these programs forward. Thank you very much. And Sandeep ji has been pestering every time. Thank you very much.
Thank you very much, sir, for your enlightening overview and your words of encouragement. Ladies and gentlemen, it is now my distinct honor to invite our keynote speaker, Mr. Rajesh Bhushan, former Secretary, Ministry of Health and Family Welfare, Government of India, and Chairperson, Governing Council, Illness to Wellness Foundation, to deliver the keynote address. Can we extend a very warm welcome to him on the dais.
Mr. Anil Rajput, Dr. R.S. Mishra, Dr. Asha Hegde, Dr. Anil Agarwal, Dr. Sunila Garg. It is indeed a pleasure, madam, meeting you after such a long period of time. And Dr. Professor Shiv Sareen, who joined us virtually, ladies and gentlemen. This is indeed, as always, a pleasure to be part of Illness to Wellness conference on different themes, and today the theme is hepatitis. All these interactions reinforce the belief in us that it is preventive health and promotive health that brings greater dividends rather than treatment-related health or curative health. So that should be at the back of our mind. Therefore, awareness becomes important. Therefore, community engagement becomes important. Now, coming to today's thematic issue, as my colleagues have already shared with you, it was in 2018 that Government of India started a structured program, National Viral Hepatitis Control Program. Now, before coming here, I was looking at some of the interventions which have been done under this program, largely through the public sector health institutions and doctors, but private sector is also doing to certain extent the same interventions. What I realized was that in the last 8 years, irrespective of whether the pandemic came or if it had not come, we would have done better. We'll not go there. So in 8 years of this program, roughly 21 crore people were screened. What is our population? 140 crores plus. So what does that tell us? It tells us that the challenge before any hepatitis program in a country as vast as India is the screening deficiency that exists today. जब तक आपको समस्या का पूरा आयाम नहीं पता चलेगा, until and unless you know the problem in all its dimensions, आप उसको address कैसे करेंगे? So therefore, screening needs to be focused both in the public sector as well as in private sector through community awareness. We must get ourselves screened. So that's number one. Then I also realized that under this program, hepatitis B and C patients who have actually been treated from 2018 when it was launched till date is roughly 6,12,000. So what does that tell us? It tells us that there is a huge treatment gap. Even if you have screened everyone in a hypothetical scenario, you have told people their status, they will ask you as a healthcare provider, ab main kya karu? So what if you have told me this is my status? The natural corollary is that we would provide you treatment or any other form of intervention. That is the second challenge, the treatment gap, which public sector health facilities and private sector health facilities have to focus on going ahead. Here, I was also discussing with Mr. Rajput that only those programs, health programs, although it holds true for other programs in our country, those health programs succeed where we adopt a saturation approach. So until and unless you do universal screening, universal treatment, treat all, jo Dr. Sareen keh rahe the, in a country as big and diverse like India, you will not have tangible results. So probably this is the right time, after 8 years of launching the National Viral Hepatitis Control Program, to look at restructuring this program based on the experience gained so far. So what does the experience gained so far tells us? It tells us that we must focus on awareness generation, we must focus on increasing access. मैं अपने को स्क्रीन करना चाहता हूँ, करवाना चाहता हूँ, तो मैं कहाँ जाऊँ? Which are the facilities which would provide? I must have access. Let's forget about Delhi, let's forget about metros, let's even forget about, areas in and around the national capital region. What about a resident of a village? Where does he or she go? So therefore, focus on increasing access. Only then universal screening and treat all would make any sense. Increasing access would then mean that greater number of people would be diagnosed and therefore greater number of people would be treated. So that should be the aim, and based on this, probably we should have a relook at the national program. Other important things are that within the national program, we are providing free diagnostics, free drugs, which makes a great difference. Therefore, can we think going ahead of an initiative of co-opting the private sector as part of the government program so that there is value addition? I'm not saying that private sector should also provide everything free, but let's take the example of the COVID pandemic. When we started, the private sector was providing RT-PCR testing at 2,500 rupees a test. By the time, 18 months passed, the prices had come down to 250 rupees per test. How did it happen? Because of sheer volumes. Government did not say, please reduce, please reduce. If government wanted, they could have said it on day one. The prices would not have started at 2,500. But over 18 months, from 2,500, they came down to 250. Similarly, if in a large program like viral hepatitis control program, government says, मेरी facilities में diagnostics free है, मेरी facilities में vaccination free है, मेरी facilities में drugs free हैं, and if the private sector joins in, their charges would also come down to a reasonable level. So that is equally important. And lastly, I would like to say that most of these interventions or programs are vertical, standalone programs. Almost like Qutub Minar ki tarah hai, कि आपने 10 कुतुब मीनार बना दिए हैं. So they must be talking to each other. Those of you who have been to Malaysia would have seen the Petronas Tower. So there are these two towers which are connected. So they are actually talking to each other. So similarly, our program for reproductive child health, maternal health, must talk to our program on viral hepatitis control, because the target group is the same. Similarly, our other programs, the non-communicable diseases program, the communicable diseases program, the drinking water and sanitation program, should also be talking to the national viral hepatitis program for greater results. So I hope that today's deliberation would focus on these issues. And as I was telling Dr. Rajput, that at the end of such deliberations, if we could share the gist of what we gleaned from the domain knowledge experts who are here with the government, that should probably take things forward. So I wish the deliberations well, and I wish you all the success. Thank you.
Thank you very much, sir, for your remarkable address. As we come to the close of the inaugural session, I now invite Dr. Sunila Garg to deliver the concluding remarks. Member FICCI Swasth Bharat Task Force, Professor Emeritus, National Academy of Medical Sciences, ex-Sub-Dean and Head Department of Community Medicine, MAMC. Can we all please welcome her?
Good afternoon, respected dignitaries on the dais, Mr. Rajesh Bhushanji, Mr. Anil Rajputji, then Professor Sareen, who is not there, but I remember him because in 86, when I joined Maulana Azad Medical College, just now I met one of my colleagues who said, ma'am, I was your student in 89, because I did my MD in 82, and then Dr. the health minister, she was my guide. And you can all imagine, those of you who have been in Sevagram, how the working is there in that rural medical college. And that's how we learned. And R.S. Mishra ji, Principal and Head of Internal Medicine. Asha ji, my own very colleague, because we have struggled very hard because I used to run postgraduate fellowship for about 14 years. Dr. Anil Agarwal is well aware of the fact, because CMC Vellore, Maulana Azad Medical College and School of Tropical Medicine, Kolkata, we started this program, and while I was here, I was thinking, why don't we have postgraduate fellowship also in hepatitis medicine? And being chair of Program Advisory Committee at National Institute of Health and Family Welfare, so these were the thoughts in my mind. And also, you know, when I look at Sarita ji from FICCI, since 2 days we were discussing that how do I, you know, what will be my role and all that. I said I have prepared 65 slides, but then, you know, they can be circulated to all for the awareness. So that is very, very important. And Dr. Jugal, so very nice to have you as my younger colleague. So it's a real matter of pride and privilege for me, you know, to be a part of this important awareness program, not only, you know, as a public health expert and as a community medicine expert, but as a member of this Swasth Bharat task force and being colleague of all of you at different forums. I feel that it is so very important to re-examine, as you know, Bhushan sir has already pointed out, that we need to kind of re-look and talk to each other, and that is why government has launched multi-centric and multidisciplinary approach. Since 5 days or 6 days, I'm looking at different ICMR projects, and I'm looking at the fact that how much each project investigators are talking to each other. And the second part is how many disciplines are involved. They say, madam, it is only related to geriatric medicine. I said, geriatric also involves males and females. It involves biochemistry. It involves, we have to talk to each other. So that's how Government of India has come out with multidisciplinary units in different medical colleges, to which I am very, very pro. And it was said that, ma'am, you are kind of approaching and approving too many medical colleges. I said every medical college must have the research component, which we should not undermine in this hepatitis control program. And, you know, basically, already, you know, during the inaugural, our distinguished experts have already highlighted the significance of World Hepatitis Day. And as I said, that when I joined in 86, Dr. Sadin used to come to Department of Community Medicine, that please send you know, your students so that they can go to rural centers, urban centers, and they can spread the message. And we would have, you know, the programs in our GB Pant Hospital or in Loknaik Hospital, Maulana Azad Medical College. And that's how, you know, hepatitis has taken over a big space when you look at, and we do have state-of-art centers also. So that is where, you know, importance is that hepatitis is much more, you know, kind of transmission, as Ashaji was pointing out, as compared to hepatitis, HIV infection. So that part all of you should remember. And another thing which is very important, that over the course of today's conference, you know, it's just the inaugural part, we are going to explore the many dimensions of hepatitis, from latest scientific developments and best clinical practices, which is very, very important, to policy priorities and public health strategies. So that part is important, and we all are united around a common goal. Basically, all of us, wherever we are, we must focus on awareness. Second is, we must strengthen the prevention part and expand access to care and improve the lives of people, and particularly when we talk of lives, means quality of life of people which are affected by, you know, not only they should be overall healthy, as Ashaji was pointed out, but today in concern of hepatitis, I am talking of that no one should unnecessarily suffer from this infection. Another thing is that this importance of dialogue cannot be overstated. We all know that over 350 million people globally are living with the disease, as has been pointed out, and many are unaware of this. And I could not give you a lesser example. 2 years back, I lost my younger brother who was a colonel in army. He just, went to a doctor and said that my wife has retired, we want to go to Germany. And he said, Doctor Sahab, Colonel Sahab, sab theek hai, keval aapki aankh thodi si peeli, aap check-up kara lijiye. When he went for ultrasound, there was a big tumor. The whole story started from April to July and we lost him. So that is where it is so much important that listen to your body and be very aware of, exactly what is happening to you. Ye nahi ki main kal chale jaunga, parso chale jaunga. So that part is very, very important. And we must, carry few messages through today's discussion, such as hepatitis is preventable, treatable, and also in many cases it is curable, which has already been highlighted through simple actions. That means testing, vaccinating, and treatment, and we can protect individuals and communities like that. And we must also, because I also was, let me take not the credit, but I was an important founder member for National Program for Prevention and Control of Deafness, and I also chair World Hearing Forum, basically with regard to deafness. And India was the first country to start this program across the world. That is important, and it carries so much of stigma and discrimination. But when we talk of any disease, in my time, at Wardha, leprosy, TB, and now when we talk of hepatitis, all these diseases, they carry still huge amount of stigma leading to discrimination. So awareness and, diagnosis becomes very, very important. Another thing is that we must together work towards the elimination of viral hepatitis as a global health priority, because we do have the vaccine which is available. So on behalf of FICCI, Swasth Bharat Task Force, and Illness to Wellness Foundation, I really extend my sincere gratitude to our distinguished speakers for basically agreeing to share their expertise and valuable experience. And also a special thanks to all of you for sitting on the other side, but your contribution to this will be very, very important. And another thing is that a special word of appreciation really goes to healthcare professionals, researchers, public health workers, and advocates who dedicate themselves every day to preventing hepatitis and supporting affected individuals and communities. And we should not undermine the importance of our young children, because we had taken care of polio because we had polio Unmulan Sena. And I remember I used to go to different schools talking to teachers and all that. When you are younger, the zeal is also very, very high. And you understand how much zeal is there amongst our young students. And Niti Aayog has already come with health promoting schools. So please make use of that and please use them as a platform. So also let us take the insights gained from here into action, whether we are talking on laboratories, whether we are talking of policy making rooms or community spaces. So together we can come closer to the global goal of eliminating viral hepatitis as a public health threat by 2030 and move towards Viksit Bharat. Another important thing is that we have to take systemic measures in form of that universal hepatitis B program. We are 148 crore people, so we have to see that when we could do so much in COVID times, because I personally was involved, and at one time I was speaking to, because when you have to speak to different people, you have to read, you have to study, you have to talk to all the stakeholders. So that is where when we could do so much, in a short period of time, and still we are working on pandemic preparedness. So it is very important our universal hepatitis B control program needs to be strengthened, and birth dose of hepatitis B within 24 hours. Asha ji, you pointed out about antenatal screening plus prophylaxis for hepatitis B, blood supply screening, and safer water sanitation, as has been already pointed out, food safety regulations, and hygiene standards. And when I went to America I'll say in 1991, and I first saw their needle exchange projects, and I came to India, we conducted the same program, and first part was, Madam, ye needle, how do we come to terms with behavior? Rather, they are dealing with, so much of, they're indulging in these behaviors, and we are replacing, with good needles and syringes, safe needles and syringes. I said, first important thing is that first come to terms with the behavior. Unless, there's a child who smokes or there's a person who is exchanging needles and all taking drugs, we have to come to terms with behavior. So that is a very important step. So opioid substitution, and you also pointed out about safe sex education and condom programs. These are important measures. We need to talk about universal precautions in all the healthcare settings. That is one thing which when you observe, and every day in morning that should be there, that we are going to follow universal work precautions between all of us, with all of us. We have no right to give information, or infection to our patients and protect ourselves with gloves. So that is very, very important to see that we do that. And another thing is that healthcare workers vaccination. We should look in our own house that whether within our own hospital all workers are vaccinated or not. And post-needle stick PEP, post-exposure prophylaxis protocols, they are very important, and education and awareness campaigns. Also, and we must aim at the target of 2030. That means we are talking of 90% reduction in new chronic hepatitis B virus and HCV infections, 65% reduction in hepatitis-related mortality, 90% people should be diagnosed with viral hepatitis, and 80% of our people should be on treatment. So these are important components. So we have to really move from illness spectrum to wellness spectrum at all fronts. So need of the hour is multidisciplinary team, that is important. The goal is not only viral control, it is to return to dignity, work, family life, and healthy aging. So these are very important. So thank you once again. We look forward to continuous collaboration and coordination. Jai Hind. Thank you.
Thank you very much, ma'am, for your thoughtful concluding remarks. We'll now take this opportunity to present a token of respect and gratitude to our distinguished and learned speakers. Can we please have the mementos? May I request Mr. Anil Rajput, sir, to kindly present a token of gratitude. We'll begin with Mr. Rajesh Bhushan. Ladies and gentlemen, let's all together thank our distinguished speakers for sharing their valuable insights with us. Can we give them a hearty round of applause, a generous round of applause? We now present it to Dr. Suneela Garg. Ma'am, to please step forward. Kindly keep the applause going. Thank you very much, ma'am. Dr. Asha Hegde, ma'am, to please step forward. Kindly keep the applause going, as this is now our opportunity to thank them for their presence, for their time. Dr. R.S. Mishra, sir, to please step forward. Dr. Anil Agarwal. And may I now request our distinguished dignitaries to kindly come together for a group photograph, sir. We would request our distinguished dignitaries to kindly come together for a group photograph. And with this, we'll also conclude the inaugural session, requesting all to please come together for a group photograph. We'll also take this opportunity to thank Padma Bhushan Dr. Professor S.K. Sareen sir also for joining us virtually. We thank you for his time and presence, though virtual. Once again, thank you all for joining us for the inaugural session. Ladies and gentlemen, we'll quickly prepare our stage for our upcoming panel discussion. We will request you all to kindly remain seated. We aim to begin in next 1 minute. Kindly remain seated and continue keeping your phones in silent mode. We'll begin in next 1 minute. Ladies and gentlemen, our stage is almost set. Once again, requesting you all to kindly be seated, as we are already running behind schedule, so we'll seek your cooperation in helping us begin in time. Our very first panel discussion on women's health and hepatitis, prevention, maternal care, and eliminating mother-to-child transmission, starting in next 30 seconds. Requesting all to please be seated. Joining him on the panel are our distinguished experts, Dr. Gargi Agarwal, Associate Professor and Senior Consultant, Department of Obstetrics and Gynecology, Amrita Hospital, Faridabad. Kindly keep the applause going. Dr. Professor Kamna Datta, Department of Obstetrics and Gynecology, ABVIMS, and Dr. RML Hospital, New Delhi. A very warm welcome. Dr. Bhavna Malhotra, Senior Consultant, Department of Pediatrics and Neonatology, Felix Hospital. Can we please extend a very warm welcome to our distinguished panelists on stage? Once again, a very warm welcome to all. And with this, I hand over the session proceedings to esteemed session moderator, Dr. Rahul Manchadda. Sir, over to you.
So we have, what, 45 minutes? Yeah, we have 45 minutes, okay. So if somebody could at the end, before our time finishes, tell me 5 minutes before, so otherwise once you get a mic, then it gets very difficult to leave it. So good afternoon, we're running a little late, so I'm going to keep it short. Many of you, or some of you who know me, will be thinking, what is a gynae endoscopic surgeon doing in pregnancy? And that's exactly my thought when Rakesh, Sandeep ji, through Anil ji said, you know, would you do the moderation? And I said, what am I going to say here? But I'm not here to talk, and I'm here to listen, really. Dr. Garg was here a little while ago, and she talked about a student. She was very kind. She said a colleague. So I was that student, really, in '89 in Maulana Azad, who studied and was tutored by Dr. Garg. So it's wonderful to meet. I met Dr. Mishra, who I worked with 26 years ago in Safdarjung Hospital. So it's been a bit of a reality check to as how old I am. And I feel like a relic with all these young doctors around me. I'm going to introduce my panel. We have Dr. Gargi to my right, who's Associate Professor, Senior Consultant, Department of Obstetrics and Gynecology, Amrita Hospital. Dr. Kamna Datta, who is Professor, really, at RML Hospital and now the Atal Bihari Vajpayee Hospital. And the person I'm looking forward to hearing from is Dr. Malhotra, who's a pediatrician and a neonatologist. Neonatology really started many years ago. I think Sakuja was in Gangaram Hospital, who started the first department there. And so you can see how old I am. So we're going to reiterate a little of what has already been discussed really in detail. And some of you might have seen the musical, which is Sound of Music. And Sound of Music, there's a song which goes to start at the very beginning. And you know the lyrics. And it says, we start at A, B, C. So here is A, B, C, D, and E, really, which is hepatitis. And also at the beginning, when we're talking about the mother and the child. So that's where we start. We heard Dr. Sareen talk about 95% comes from transmission. So let me now start with maybe Dr. Kamna. And let's hear from her experience about what she feels about hepatitis in women per se, and of course, maternal, how much she sees, and then of course, we can hear from you also as far as the, your experience, because we have wonderfully curated this. We have the government setup and we have a private setup. So we should have some experience. So please do tell us about the incidence and the burden in our country, in women, and pregnancy?
So, a very good afternoon to all of you. And hepatitis per se is basically divided into infective and non-infective for a general person to say. And as far as the incidence and the burden in our country is concerned, we will be talking more of hepatitis B and C because they have a good amount of data collection, whereas hepatitis A and E are not that well recorded as far as the numbers go. So these are all infective hepatitis. And when we are really concerned about vertical transmission, it is this kind of hepatitis which we are really concerned. So when we talk about hepatitis B, we have already learned almost 350 million people in the country are affected with hepatitis B. And out of these, roughly 50 million are women in the reproductive age group. So among these 50 million women in reproductive age group, there are roughly 5 million pregnant women who are carrying the hepatitis B virus. When we talk about hepatitis C, this figure goes little down to 1 million, but it is a significant number we are dealing with. Hepatitis A and E, although less in incidence we found because they are not chronic infections, they are relatively acute infections. They occur in a relatively less they are less prevalent, but hepatitis E here is what I want to highlight is very important for us obstetricians because this virus carries a very high mortality during pregnancy. So that is how, this is the importance of hepatitis E.
In your hospital, in your practice, Doc, what is the frequency of patients that you maybe deliver with hepatitis, and what is the most common one that you see? And any interesting anecdote you'd like to tell us?
Surely, as we have already heard, that hepatitis B and C, they are the most important ones as they lead to chronic hepatitis, the most debilitating morbidities associated with it. And mother-to-child transmission, that is the vertical transmission, it forms one of the most important burden where we can focus to reduce the transmission of B and C hepatitis. As Madam said, E hepatitis is very important for us obstetricians because it presents as an acute fulminant hepatitis. Although we see very rare cases in our practice about hepatitis E, but we as obstetricians are always very vigilant when a patient with jaundice comes to us in that perspective to rule out hepatitis E virus. As far as hepatitis B and C are concerned, definitely the diagnostic part is becoming very relevant now because of the viral checkup that is being routinely done and universally done nowadays in antenatal clinics. The incidence of B and C is fairly, as much my experience is there, it is fairly common. Nowadays as well, we see patients where they are completely unaware that they were having any such kind of illness, and rather they become very surprised when the report comes and they come to know that, okay, they are having hepatitis. And therefore that raises multiple of questions from those ladies and their families.
So now that we put experienced really her story, and it's been very I must say what she's been through. This is a story of probably many households in our country. So prevention, I feel, and this is what we're talking about, illness to wellness really, is what we're looking at. Prevention is something which is very important. So how do we do prevention? What are the diagnostic techniques that we use? When I operate on a patient, we do a hepatitis B screen, a hepatitis C screen, and an HIV before going into the operating theater. So during pregnancy, what tests are done in order to diagnose this?
Right, so when we talk about hepatitis, we'll talk about hepatitis A and E in one go and B and C in one go. So when we talk about hepatitis B, the government of India, as well as all international bodies, do say universal screening for all women. So even in India, we screen all women who come to our antenatal OPD for hepatitis B. Hepatitis C is not in the universal screening program, but again it is a recommended test because hepatitis C is again a silent virus which is in the body. And another thing associated, why it is important for us to know whether the hepatitis C is there or not, because if these two viruses coexist, then the course of the disease becomes very severe and aggressive. So for us, we do HIV, hepatitis B, hepatitis C antibodies and VDRL as part of routine screening. And not just the lady, we also prescribe these tests for the husband.
Interesting. So I know I've left you out, Dr. Bhavna, but I was thinking of coming to you at the end, which is your forte. But let me sort of bring you in a little bit, and this is just an sort of off the cuff thing. When you know you're going to look after a baby that is being delivered with say a person who has who's positive for hepatitis B. And you get a call from the obstetrician saying, okay, I'm going to deliver this baby and could you be there? So what are you looking in the history that you would like from the obstetrician so that you can prepare yourself? I'm not coming to the standard question that I'm going to ask you later on, but what would you like? Because as an obstetrician, maybe we could be more aware that this is what you would like to know so that you can prepare yourself for this little child who's coming.
Yes. First of all, the status, immunization status of the mother. Second of all, HbS-Ag status of the mother. Third, the most important fact which we would want to know as a pediatrician is hepatitis E antigen. If it is positive, it has transmission rates of more than 90% to the baby. And if that HbS-E antigen is negative, the transmission rates are less as compared to 90%, it reduces up to 30 to 40%. So with the mother having hepatitis E antigen positive, we are all the more specific to give active as well as passive immunization within the first hour, so that we can initiate with safe breastfeeding practices and further limit the spread of the vertical transmission, which we know is the most, we have the most cases from the vertical transmission only. In utero transmission as compared to other causes of transmission, the vertical transmission carries the highest rate. So to prevent that, single most effective intervention is to vaccinate the baby within first hour. As we increase the time, as we take it up to 12 hours or up to 24 hours, the infectivity reduces. The infectivity of the dose reduces. As we vaccinate, the outcomes are not as good as if we vaccinate within 1 hour of the birth.
So it's actually the golden hour that you're looking at?
Yes, the golden hour, and the earliest, ideally within 12 hours. As we grow later to the 12 hours, we are more on the side of losing the babies to HPV chronic infections.
Okay, interesting. Now, if the baby is, say, IUGR or growth retarded or comes out early, would you be more sort of?
Yes, sir. Sir, even if the baby is less than 2 kgs or more than 2 kgs, as we divide on the baby's weight, we are supposed to give babies, we are supposed to actively and passively immunize whatever is the gestation, whatever is the weight, immediately after the birth, as soon as possible. And preferably, ideal time is before 12 hours after delivery.
So it's interesting to know, because we always look in medicine, in any emergency, we're looking at the first hour. So it's very interesting to know that even, I mean, I didn't know this. So, you know, one would hurry up and say, okay, let's look at giving the vaccination in the first hour.
Sir, as per WHO, it is a single most effective intervention, vaccinating the baby immediately after birth within first hour. Single most effective intervention amongst all the programs of hepatitis B.
So Dr. Gargi, let's come to you. For somebody who's like me, who didn't know this, and a lot of obstetricians don't know this, okay, gynecologists, obstetricians. So what would you want to, how would you want to increase the awareness for such lay people as me, in order to, so that we know this, and if we are encountered by this, or maybe we can then further spread the word, which is what everybody here hopefully will do. What would you want to do? What are the awareness programs? What else would you think we could, get the message out there? How would you do that with obstetricians especially?
I just want to emphasize this, that we have been talking since morning about how much burden the hepatitis is, what are the cost factors which are involved, because it is such a huge burden that even to screen patients, to diagnose, firstly of course to prevent, and then to screen the ones, then to diagnose and treat them further will definitely will have such a huge burden. So why not, along with all these processes, try to reduce the burden of MTCT, that is mother to child transmission. The main awareness factors is because as gynecologists and as obstetricians and as general physicians as well, we come in contact with many families. We can counsel them generally just to get their health checkups regularly, and and apart from their liver function tests, their kidney function tests, and apart from those, they can get their routine viral markers as also done routinely. As far as antenatal patients are concerned, I guess all the obstetricians, they are nowadays carrying out those triple elimination protocols, and they are checking for viral markers, and as well as HIV, hepatitis, and syphilis testing is already being done. But this checkpoints where families are coming to us, where the women are coming to us, and they are very open to us, to the gynecologist, and they are quite open in discussing many problems. Then apart from various other problems, like many things that we discuss with them, we can counsel them to get those basic tests done, even if they are not coming as an antenatal females. So this is very important, that in age groups like even reproductive age group, or they have passed their reproductive age group like perimenopause or menopause, they can get themselves checked. This is very important message that they should receive.
So we are actually, like you point out, the first sort of window to most families, the gynecologists, the families, sort of when they come to us, we're delivering babies, we're looking after women in the family. So we are somebody that they turn to. So giving that message out, even as a general message about hepatitis, I feel we can bring that to many more families, because we're dealing with the families, and therefore the word can go out. So that's very important. Now, if I was to come back to Dr. Bhavna, now, you said the first hour is important. That's important for us to know. Can I ask you again, which is again something which we don't know, if there's a mother who's having a baby and she's very anxious, she's sort of hepatitis B positive or even C, she's worried about breastfeeding. Yes. Can she, can't she, will the baby get it? Forget the mother-in-law is very anxious. Will the baby, if it's a male baby, that's even worse, you know. So will the male baby get it? Will he get a disease? Will he live? Will he not live? What would you advise? What would you tell them? I'm sure this is a whole big sort of subject there. But I think if you would sort of elaborate a little bit more, because here not only the women should know, but I think the men should know. It's important for the men to know, probably more important than the women. So the male should know how to treat everybody in the family. So tell us a little bit more in detail so that we can sort of dispel those fears, if there are any, and help others and take that message forward.
Yes, sir. Sir, a baby born to a mother with HBsAg hepatitis B antigen positive status, whether HBs E antigen is positive or HB viral load, HBV DNA once we do is more than 2 lakhs international unit per ml, whatever may be the case, there is no contraindication to breastfeeding. I would want to repeat myself, there is no contraindication to breastfeeding. There's only one contraindication to breastfeeding, that is, if a mother with positive status is having mastitis and is having cracked and sore nipples from where actively is bleeding, the nipples are actively bleeding, and there is a contamination of the blood with milk, then there is only one single contraindication where mother cannot breastfeed the baby, whether it may be the viral status load or HbS positive status, provided, sir, if we have given within first hour active and passive immunization to the baby, then only she is allowed to breastfeed. If the mother is HbSAg positive and we have given active immunization to the baby and we are not able to give the passive immunization, still baby can breastfeed, provided mother does not have sore nipples and there is no bleeding from the nipples. And as compared to if the mother's status is positive, what we do for the baby is we immunize the baby at birth within first hour. Best is if we do it within 12 hours. Followed by that, we complete the 3 series. The first dose only confer the immunity up till 55%. All the next 3 doses are to be taken on time. So we give the first dose at birth 0, then at 6, 10 and 14 weeks consequently. And sir, if the baby is less than 2 kgs, the first dose is given at the birth, followed by that the initial dose we start at the 1 month of age. And we are supposed to complete all the 3 doses. For a baby born to a mother with positive status, how are we supposed to follow up with the immunization now? After the first after the birth dose, three immunizations are to be given, 0, 6 and 14. Followed by that, at the age of 9 to 12 months, I would want to repeat myself, at the age of 9 to 12 months, or if the baby was preterm and was discharged late or the vaccinations were delayed for whatever reasons, after the last vaccination, 1 to 2 months after the last vaccination, titers are supposed to be done. HbS status as well as the titers. If the antibody titer is more than equivalent to 10 milli international units per ml, then our baby is protected. If they are less and HbS status of the baby is positive, then we are supposed to revaccinate the baby, sir. We would check for the titers after all the doses are complete, 1 to 2 months after all the doses are complete. We'll first vaccinate the baby with the 4 doses, 0 dose, 0, 6, 14. Followed by that, we'll wait for 2 months, we'll check the antibody titers. If the titers are more than equivalent to 10, then we can be happy that the antibody titers are produced and our baby is safe. If the titers are less than 10, then we are supposed to revaccinate the baby, all the 3 doses. Followed by that, 1 month of that we are supposed to check for the titers. If the HbSAg status is positive for the baby, and even after the vaccination it comes up to be positive and it is positive for more than 6 months, then the incidence for HBV chronic infection is more than 90%, sir. So the only single one intervention which we are supposed to do to prevent this long-term hepatitis B vertical transmission is birth dose followed by the 3 other doses. Birth dose only confers immunity up to 55%, second dose gives 75% of the immunity, and third dose, and third ke baad 4 dose gives more than 95% of the immunity.
So it's, if it's confusing for me as a gynecologist, I don't know how confusing it will be for the lay person. Having said that, to sum it up, please go to a good neonatologist like Dr. Bhavna and keep following it up till the vaccination is over and she puts the red flags there, okay, that's enough.
I'll make it very easy for all the gynecologists all of you to take home as a take-home message. After birth, first dose immediate, within first hour, preferably within 12 hours. And if the mother's status is positive, then active and passive immunization, first dose. Followed by that, in the universal immunization status, we have 3 doses, 0, 6 and 14. That's it. Followed by that, sir, all the vaccination is complete. Now we are supposed to know whether our baby has got the infection, mother's status was positive. So we'll check for the antibody titer. Once we check for the titer, if it is more than 10, we can be happy. If it is less than 10, then we give another chance to revaccinate with all the 3 doses. Once we have revaccinated, again we'll check for the titer. If it is more than 10, we can be happy. If it is less than 10, then we should be sad, as the baby would be carrying a high risk of transmission to a chronic HPV patient.
So this brings me to ABDM. which is the digital mission started by the government of India. And I think that's a wonderful thing. And I was talking to somebody here. I was talking to Dr. Agarwal actually, and we were talking about how India was way ahead during the COVID immunization program, because we had our immunization protocols in place right up till the last mile with the other immunization programs that we have, and we were able to reach them. Similarly, I feel that with this, we can, with all the records and that you've said, the ABDM gives us a good platform where all the records are there, and it can flag maybe red flags on those who need a follow-up, who need to be vaccinated, immunized, and might need also a specialist intervention which can be done remotely. Now, after the immunization of the baby, let's come to women. Women's immunization, that's where it comes from. So tell me, Dr. Datta, what do we do as gynecologists? How do we sort of follow them up? And when do we give them the vaccination during their pregnancy, if at all?
So once we presume that a lot of children are vaccinated and now the coming generations will be vaccinated, but that doesn't say that they cannot get infected. So one is that, yes, first test we do is HBs antigen, which will detect whether there is any virus or not. So it will just tell us whether there is any infection. Whether the lady is immunized, has protection against the virus, that we will come to know by the antibody titers. And that holds true for every one of us. We feel that we have been vaccinated once and we are immunized for life. It isn't like that. For all of us here, we should get our antibody titers checked at least once in 10 years. And if the titers are less than 10, then we need a revaccination. That holds true for pregnant women also. As far as hepatitis C and E are concerned, there is no particular vaccine. Hepatitis A vaccine can be given only to women who are at a high risk of contracting these infections, which means either they are immunocompromised or the water and food sanitation facility is not good. It is not an absolute contraindication during pregnancy. But other than pregnancy, it can be given widely, and we should all take hepatitis A vaccine, especially where the water and food sanitation is at a question.
You know, when I was in college, we were, because we were sort of medical sort of staff and all, we were given the hepatitis B vaccine free. So we were all very happy, you know, we would go and get our thing written by our medical CMO there, and we would get free vaccines for hepatitis B. This was way back when. So that was there. But what I wish to ask now, which is an important part which we probably missed in the discussion, is really delivery. So if you have hepatitis B, C, HIV for that matter, is there any difference between doing or having a normal delivery or going in for the cesarean section? And how would you sort of prevent transmission or make it as less as possible around that time? You know, by what are the measures that one can do? And of course, if there's any any truth in mode of delivery being safer.
So the basic concept is that for preparing for the delivery, first thing is to decrease the risk of transmission at the time of delivery. The preparation has to start prior to delivery. The basic concept is the same, that is the viral DNA levels should be as low as possible in the body. The viremia should be less, and if the viremia will be less, the transmission from the mother to the child will become as low as possible. And therefore, further, when the baby will be vaccinated, the chances, the percentage will further go down. So as far as even in HIV, in hepatitis B, hepatitis C, whenever a lady comes out to be positive, maternal viremia or the, like for example, if she comes out to be hepatitis B positive, hepatitis B DNA, the load can always be done, and it should be done to ensure that how much the viral load is going, what is the status of the disease in the lady, what are the chances of transmitting the disease from the mother to the child, and can we have or can we offer some medications, some drugs, some pharmacotherapy to the lady to decrease that risk. So that preparation first should start in the antenatal period as well. WHO has also come up with an update regarding starting of diagnosis, carrying out hepatitis E antigen just to ensure the infectivity level, hepatitis and HPV, hepatitis B DNA viral load levels in around 24 to 28 weeks. And if the load is more than 2 lakh IU copies per ml, then even TDF has been offered in pregnancy for females to decrease that maternal viremia at the time of delivery. So this is very important that the patients who are coming out to be positive, of course, they have to be counseled properly to get themselves tested further and to ensure that there are certain precautions that can be taken in the antenatal period to decrease the chances of transmission to the baby. Then coming over to the second part, that what will be the mode of delivery? This question is very important because nowadays we all are propagating and offering and performing evidence-based medicine, evidence-based obstetrics. And as far as the infectivity, the positivity of the patient regarding these viruses or hepatitis is concerned, the mode of delivery will always be preferred, always be as a vaginal delivery, normal delivery, and the cesarean section is not to be indicated in all such patients unless and until it is obstetrically indicated. So this message has to go forward, that evidence-based medicine and not the defensive-based medicine should come up, and there is no such indication in such females that cesarean section or operative methods should be done. Then secondly, there are certain practices which can be followed during a routine course of labor when the lady is induced or she goes in labor. For example, some invasive fetal monitoring that are being done, they should be avoided. Then prolonged rupture of membranes where the chances of transmission of infection from mother to baby during the course of labor, once she is in labor, baby should not be exposed to the maternal fluids for a prolonged period of time. So that time should be decreased to as low as possible. So there are various methods which are being taken by obstetricians when they care for such patients. And then further, of course, the counseling by pediatricians and the important vaccination of both active and passive that is being done. It is again being counseled to the family by, usually we send these patients before hand to a neonatologist or to a pediatrician so that they can get prepared for their child, that okay, within that golden hour they need to be prepared, they need to be counseled that the vaccination has to take place.
Would you like to add anything?
I would like to add, Dr. Gargi, very well said. All these methods, just a small message, that all these methods, when combined, can decrease the rate of transmission from 80 to 90% to less than 1%. So every step becomes very important. And as we've been reiterating since morning, early detection of the disease will make the process very simple.
Let's go back to breastfeeding. Now, you did mention about the follow-up, the immunization status and everything. Is there any specific safe measures that one can take for I remember a lot of my patients when I was working at Safdarjung would sort of come up and ask me, you know, will the baby get by breastfeeding? Can we do anything which is safer, you know, for that we avoid or not?
And best method is to initiate breastfeeding immediately after vaccination. And best method is if they inform us as soon as the patient is admitted so that we can indent for the immunoglobulin. Hepatitis B vaccine is easily available, but until we give the immunoglobulin, we do not feel it safe for the mother to breastfeed the baby. 100% safety, for 100% safety. So if all the gynecologists inform us immediately as soon as the patient is admitted that the patient's status is positive, so that we can ask our nursing staff to indent for the immunoglobulin, and immediately after the birth, if we give immunoglobulin and start start with the breastfeeding. That is the best possible way. We avoid mixed feeding in the patients having mother having positive status or where the transmission rates are high. It is told to the parents, to the mothers, as well as specifically to the grandmothers and grandparents that this breastfeeding would be protective for the baby. There is very little or minimal risk of virus transmission through the breast milk, which is almost nil. The most of the virus is transmitted only through vertical transmission. In utero, as well as the transference from the breast milk is almost till nil. So it is usually protective for the baby. Breast milk is usually protective for the baby in saving baby from the other infections where baby can be, feeding from the top milk can lead to other various disastrous infections to the baby and further lead to decreased immunity. So for the best immune status of the baby, even if the mother is positive and baby's status is also positive, if the baby has been immunized actively and passively, the only best method to feed the baby is breastfeeding. Only one contraindication, that is what I told you earlier, if the mother is having bleeding nipples, that too. Specifically, WHO mentions if the blood, if there is major amount of mixing of the blood with the breast milk, minimal amounts still can be ignored. And if the mother is having mastitis without bleeding nipples, she can still feed the baby.
So these are some important take-home messages which you've mentioned, and I think people are sort of worried always in these situations. So this is something important. So we've talked about awareness in gynecologists and lay people. We've talked about screening during pregnancy. We've talked about mode of delivery, and in herpes and all, I know if there are active lesions, then we then advise to do a cesarean section, but that again has been put aside by both of you wonderfully. We've even talked about the baby and the golden hour. I think you would like us to finish. Maybe I'll take another few minutes and ask each one of you if I will, may I start with the latter end, which is the baby. Maybe one take-home message or message that you'd like to give everybody?
One single most effective method is to immunize baby immediately after birth. Please don't delay vaccinations up till 12 hours or up till 24 hours. Immediately as soon as the baby is born, vaccinate the baby and latch the baby to mother's breast so that we fall out of dilemma of thinking whether we need to mix feed this baby, mother is not producing enough milk, or the parents come into dilemma कि mother का उतना milk नहीं आ रहा है, डॉक्टर साहब ऊपर का दूध देना ही पड़ेगा. So to avoid all those confusions, the best way is to immediately vaccinate and immediately latch the baby so that we can further limit the spread of the disease. If only providing first initial vaccination देने से ही 90% of the transmission rate वहीं पे we can stop it, and we can prevent baby from having HBV further chronic infection. So the only one single most effective method is vaccinating in the golden hour before 12 hours are complete.
Dr. Datta?
Sir, I will say two messages. One is a preconception testing. We should all get ourselves tested for hepatitis B antibody levels, presuming we are antigen negative. Antigen and antibody testing both are important. Second, we have been talking about hepatitis B and C. Both of them are blood-borne transmission. We are somehow forgetting A and E, which are very morbid diseases. And for them, hand hygiene is one message I would like for all of you to spread. Hand hygiene is very important. Of course, water and food is something on a larger perspective, but at a personal level, we should all encourage hand hygiene.
Dr. Gargi.
I would like to emphasize the multidisciplinary approach in all of this, because I feel the bottleneck in MTCT or our mother-to-child transmission is not always the medical knowledge, because we all have access to lots and lots of platforms and books and everything nowadays. But I feel what is important is that if it's possible, we can have a unified kind of a checklist that starts from antenatal period, that includes not only obstetricians as well as the gastro people, the medicine physicians and everyone, so that the antenatal females can move ahead in their antenatal journey comfortably. And that antenatal, that checklist of MTCT can be passed on to the neonatologist as well, and they can also follow up the baby properly up to 9 or 12 months, and so getting it immunized, as well as the proper antiviral drugs, all those screening and treatment, if the lady needs any treatment for that disease, that can be given to the female. So that integrated approach will also help the female to get the right treatment and also to decrease this transmission as low as possible.
So I'd like to thank all of you, of course. You've been a wonderful, you want to
Yes,
say
sir.
one thing? Yeah.
Sir, we have missed on adolescent and catch-up vaccinations. So after the birth dose, before we send our babies out for colleges, it is a must that we give them catch-up vaccination again for HPV as well as for hepatitis B. Before sending them out for medical colleges, for engineering colleges, or before sending them out for higher studies, birth vaccinations are included in the national immunization program, but the catch-up adolescent vaccinations are most of the time missed by us. So that is the one method which we, by all of us, before sending our babies out for the higher education, it is must that they should be vaccinated for all the 2 doses of HPV if they are less than 14 years of age, 3 doses more than 14, and all the 3 doses catch-up immunization for hepatitis B, and if possible for hepatitis A as well.
So thank you for bringing that up, which is the HPV vaccine that you talked about, which is...
Sir, all the 3 vaccines are given together. So they are combined, mostly hepatitis B, followed the adolescent vaccination, hepatitis B, HPV, and if SOS required, hepatitis A for catch-up.
That's my field, okay? Because we're talking about cancer cervix now. So I'm happy you eventually brought me in here. But yes, I have 2 things that I'd like to say. I have thanked all of you. But first is, I am impressed because I now know that it is possible to have a room full of people listening to a women's health panel, especially more men in the audience than women, so that's wonderful. And of course, my message would be, which I've been doing now for many, many years, we've been doing, and that's how we come with the illness to wellness, is that do look after the women in your family. Because women, of course, are the most important spoke in the wheel. And if the woman and the lady in the house goes for a 6, everybody goes for a 6. So whether it is hepatitis B vaccination or HPV vaccination, that needs to be done. And of course, by protecting them, by taking care of them, we do that for the whole society as well as the nation. So thank you to Illness and Wellness, the complete organization, Mr. Rajput. Again, we have a long way that we go way back. It really is wonderful to be here. Thank you, Rakesh and Mr. Jain. And thank you for having us here and for being a wonderful panel. Thank you.
Thank you very much for that stimulating discussion we just had. Would request Mr. Anil Rajput, sir, to please join us on stage for the presentation of mementos, a token of appreciation to all our esteemed and learned speakers. We'll begin with the esteemed session moderator, Dr. Rahul Manchanda, sir, to please step forward. Would request Mr. Rajput to please present a memento. Ladies and gentlemen, please put your hands together for Dr. Rahul Manchanda. We thank him for his able moderation. We now felicitate Dr. Gargi Agarwal. Ma'am, to please step forward. Kindly keep the applause going. We now thank Dr. Professor Kamna Datta to please step forward. Dr. Bhavna Malhotra. May I request all our esteemed speakers to please come together for a group photograph with Mr. Rajput. Kindly come together, come forward for a group photograph. Thank you once again. Ladies and gentlemen, I will request you all to please remain seated as we'll now prepare our stage for our upcoming panel discussion. We'll take 30 seconds, so kindly remain seated. Our upcoming session focuses on integrated approaches to viral hepatitis prevention, vaccination awareness, screening, and early intervention. Our upcoming session will explore how vaccination, awareness, early screening, and timely intervention can work together to accelerate India's journey towards eliminating viral hepatitis. And as we can see, our stage is all set. Please join me in welcoming on stage our esteemed session moderator for this session, Dr. Kapil Dev Jambal, Chief Innovation and GI Interventions and Head Gastroenterology and Hepatology, Artemis Hospital. Can we all together please welcome our esteemed session moderator? A very, very warm welcome to you. And give me a minute as I invite our esteemed speakers. Now I request our distinguished panelists to kindly join our moderator on stage. Dr. Anita, Scientist E, Hepatitis Group, ICMR, National Institute of Virology, Pune. Kindly keep the applause going. Dr. Manoj Gupta, Senior Director and Head, Department of Robotic and Laparoscopic GI Surgery, GI Oncology and Liver Transplant, Yatharth Super Speciality Hospital, Greater Noida. A very warm welcome to you. Dr. Professor Jugal Kishore, Director, Department of Community Medicine, VMMC and Safdarjung Hospital, Ministry of Health and Family Welfare, Government of India, New Delhi. Can we give them a more energetic round of applause? Dr. K. Madan Gopal, Senior Health Sector Expert and former Senior Consultant Health, Niti Aayog. Once again, a very warm welcome to all our distinguished panelists. And before we commence the panel discussion, may I invite Dr. Anita to deliver a special address and presentation. Can you please welcome her on the dais?
Very good afternoon to all of you. Actually, the stage is already set and my presentation is like, I can skip most of it because it's being discussed since morning about the diagnosis of hepatitis. But I'll just focus on the diagnostic challenges which we face. I'm a laboratory scientist working as Scientist E at Hepatitis Group of ICMR and IB Pune. So what we deal there is with the outbreak investigations and the referred cases from different parts of the country and different challenges. So I need not to talk about the differential diagnosis of the hepatitis viruses, as the esteemed panel, earlier panels have already discussed most of the cases, how the hepatitis is presented, what are the symptoms and all. This is not for specifically for this panel. But if we as a laboratory person has to classify it, then we classify it as a viral hepatitis, toxic hepatitis, as well as the other causes of hepatitis. We look forward for the blood-borne hepatitis viruses as well as the enterically transmitted or food or waterborne transmissions of the hepatitis viruses. We look for HBV, C and HDV as well. When we we have referred cases or the outbreaks which are going on and referred to us. There are other causes of hepatitis which as an investigator we look in case of this referred cases for like non-hepatitis viruses like yellow fever, CMV is there, rubella, mumps, Epstein-Barr and herpes simplex. They can also present with the similar kind of symptoms. These are the 5 types of viruses like A, B, C, D, E, which has been like more cause of viral hepatitis overall, like around 304 million people, they have been reported living with hepatitis B and C. So WHO has set a really an ambitious goal where to eliminate the viral hepatitis by 2030. And we as a government institute and various private institutes, we are working together for the elimination program, and which starts with I can skip most of it, like if we specifically talk about the right diagnosis, because right diagnosis is very important when the treatment has to start by different clinicians and different healthcare professionals. So this is about the general virology part of it. What is the right diagnostics? Like for hepatitis viruses, most of the cases are diagnosed by the IgM ELISA. For here is the case of hepatitis A virus, where IgM antibodies we detect within 5 to 10 days after the symptoms onset, and they can be detected from around 4 to 6 months, followed by hepatitis anti-HAV IgG antibody and HAV RNA as well. But there are challenges in hepatitis A virus diagnosis as well, like the viremia. It's a short-lived viremia, and persistence of IgM might be sometimes misleading. It may not be an acute infection by that time. So, as we all are aware that it's can be fully recovered, and there is a vaccine available for hepatitis A virus. So, which is being referred by different clinicians based on the program. So, I would like to share a few of the stories where we were investigating certain outbreaks, and we are seeing a change in the age group of hepatitis A virus outbreaks now. So here in one of the outbreak which was investigated in January, where we started getting the cases in around 19 to 30 years and more than 30 years. So we are getting a lot of cases with the adolescent age groups as well as in the younger adults as well. So there has been a shift which is going on silently, and which might be like we miss sometimes. So we tried to see what is going on during this outbreak. So again the same, that is genotype 3A, which is being circulated in our country, is the same virus there in adolescents as well. But we are seeing some mutations as well in going on in the virus. So currently it has not affected as such the treatment and other protocols, but they are the important mutations in especially the viral replication, which might affect the viral replication dynamics as well as the antigenic properties. So it's very important to look into what genomic changes are going on currently during various referred cases or the outbreaks. Similarly, for the hepatitis E, which is again many a times underdiagnosed, I must say, but it is related to severe cases which are being reported now. Same case of scenario here is like in current and acute cases we can detect the RNA, but we can detect in chronic cases we should look for the anti-HEV as well. Same kind of a scenario when there are challenges involved, that is weak antibody response in immunocompromised patients might be misleading. Then there is a chronic infections which often can be missed. These are typical things which we keep on encountering when we diagnose certain outbreaks, or we have to investigate the outbreaks. There is a hepatitis E vaccine available in China, but currently it's not available till now in India. Coming to B, we all are, like all clinicians and all healthcare professionals and as well as WHO's program talks about hepatitis B and C elimination. So a lot of thing is already being done about hepatitis B and C, and since morning we are discussing about the right diagnostics for the hepatitis B and C as well. For hepatitis B, there are specific significant markers which you all are aware of, like HBV DNA indicates the active infection, HBsAg is a hallmark of infection, then anti-HBs, if it is present, then we can consider that it is in the recovery phase. So these are for the research purposes different diagnostic markers which we use in our lab setup to understand about the infection in a specific referred cases, or if we are following certain referred cases. There are challenges again comes with the hepatitis B infections as well, like covalently close circular DNA. It cannot be like easily measured. So in that case, the liver biopsy comes in picture, and which is an invasive method. Also, like only there is a window period which is there for the detection. Only IgM and anti-HBs remains detectable, and there is a failure to test anti-HBs IgM antibody, which might be again misdiagnosed. So this is for clinical specific diagnostics approach. There is a vaccine, I need not to stress on this. I would like to highlight one of the outbreak which we have investigated recently in February, where a lot of samples were referred to us from Haryana. Earlier it was suggested that it might be something else which is going on. So we investigated it for the hepatitis B and C. And again, our role is to check whether what genotypes are circulating, if there is something going on differently. So we sequenced all the samples, and again HBV genotype D1, which is common genotype in India, we could detect. And here in this outbreak, hepatitis B infections appears more prominent, and some of the recent infections were suggest that there is an ongoing transmission in that particular village in Haryana. And we also detected HBS antibody presence, which might be the earlier or past exposure to the virus. Similar way, when we tried to understand the mutations, which are very important mutations which are going on in pre-core, we call it as a pre-core mutations or basal core promoter mutations. That are related to, in these patients we have seen certain specific mutations like G to A, then A to T, which had a higher tendency to develop a liver failure in those patients, especially with genotype C. And therefore, genotyping and detecting the mutations is really important when we have to work towards the elimination of hepatitis B and C. So, and that's what is the role of ICMR NIV Pune when it comes to these programs. It's not only providing diagnostics, but to go ahead and do further to understand more about it. I'll skip about the C. This is the infection identification testing sequence which is being followed as per the CDC guidelines in the laboratory setups. Considering the time constraint and the already known information, I can go ahead and skip few of the informations. For C also, we face a lot of challenges in diagnosis, like in immunocompromised patients. There are cases that we might fail to diagnose these kind of patients. So in that cases, the HCV cases, HCV RNA is the gold standard method which we follow in the lab. But there are different genotypes, and considering the RNA genome of HCV and continuous the selection pressure, as you know, the DAA associated direct antiviral treatments are available for HCV, and the resistant associated substitution mutations have gained a lot of importance nowadays for the clinicians to decide on the treatment strategies. So we need to check if there is a specific mutation happening because of the direct acting antivirals. So these kind of things are important for designing or for the therapy for HCV as well. Coming to the D infection, which is a co-infection with B, sometimes it is not diagnosed because it is not referred as such to go ahead to check for hepatitis D as well. But that can also lead to a severe outcome like hepatocellular carcinoma and a decompressed cirrhosis as well. So detection of HDV is also important in HBV positive or HBs AG positive cases. This is like about vaccination against B. We discussed in the morning and in the earlier session as well, but it does not provide protection against HDV if it is already infected patient with HBV. There is a recommended testing protocol as well for HDV testing. So we usually go for IgG testing. If it comes IgG positive for HDV, then we go for real-time or RT-PCR for RNA detection, and then we detect it as an active HDV infection. I will just focus on whatever we are doing as a ICMR institute. So the core contributions of ICMR in terms of understanding the host virus interactions, we are more into a strong solids team of epidemiologists who work for the outbreak investigation. We are working on discovery of different biomarkers and vaccine candidate developments. Major achievements is understanding or characterizing, we have recently characterized a simian HAV, which is genotype 5. Then we have also identified genotype I for HBV. There is a molecular virological work which is going on in understanding various markers. Various epidemiological studies are on the way for understanding the things. The current progress is understanding about the role of exosomes, because these are non-invasive markers which we can explore for hepatitis or all hepatitis kind of infections. So we are trying to have common exosomal markers signatures. Maybe for HIV, it will be a different marker, B, C. Similar way, we are trying to explore it and try to relate it with the clinical outcome and severity. So this is how at ICMR we are contributing towards the goal of elimination, where we know that the testing already exists, there is a treatment which is already available. We have to break the barriers to the access, as discussed in the earlier session as well. So if we break those barriers, then definitely we are near, in fact, on a track up to some level for achieving the goal by 2030. So thank you. And thank you to the organizers for providing the opportunity for sharing the work which we are doing at ICMR NIV Pune. Thank you so much. Thank you.
Thank you very much, ma'am, for that informative presentation. I request the esteemed moderator to kindly now lead the session.
Yeah. Good afternoon. Thank you, ma'am. As a clinician, I will say that liver is a very tolerant organ. So liver doesn't get injured very fast. So all this hepatitis or alcohol takes time. So normally we say that from the insult to the cirrhosis will take around 20 years. So why we are worried now is that about two types of viruses. One, I have already explained. One is like chronic viruses, chronic B and C, and A and E. Over the years, last decade, what we have seen is that A is the culprit. It is the most common cause of liver failure, and for our centers, like he's a surgeon with me, so we have we can say referral for liver transplant is acute hepatitis A over the last decade. So we do normally want to do transplant for hepatitis A, especially in this season, in a month. Second is hepatitis C. After the advent of the direct anti-DAs, so hepatitis C is not a problem for us because 99% of virus, or it will be cured by the medications. So what is challenging and for all of us is hepatitis B. Why hepatitis B is challenged? Because one is despite having a good vaccine, despite having medication which can control the disease, despite having good programs. So that's why there's an elite panel which includes public health expert, lab expert, clinicians, as well as informants. So what we will discuss is what are the goals, and we'll start one by one what can be done. So ma'am, I would like to ask you is, could you briefly describe what is the present status of the WHO program, or what the target set by WHO is, that elimination of hepatitis B, and where are we, and what do you expect by next 5 years?
Actually, from 2018, like NVHCP has a very good program for HBV and HCV testing, where they are taking care of free treatment, providing the diagnosis free. So we are on track, but there are still a lot of gaps related to the screening, because screening is a phase where a lot of things are missed. And the earlier panel also discussed about the importance of screening. If we detect the case in a right spirit or get tested in a right time, then we are on track, I must say. But there are gaps which we need to fill, and then only we'll be able to achieve it by 2030. Maybe a little later, not by 30, but government is supporting different programs, and through which we will be able to at least near the goal by WHO.
Yeah. So I think what she's saying is right, because we have been trying, but we have not been able to match it. So I will ask Professor Kishore. So you heard about the perspective of enforcer. So what, at your standpoint, how can we translate into a public or population-based impact so that people will benefit more?
Thank you very much for the organizers Actually, I was thinking that teaching the educated one is not a good idea. I'm from public health, and I request Sandeep ji and also the Anil ji to have more such programs, awareness program to people and public rather than in VIP suits or maybe the hotels like this, because the impact would be less as compared to when we think of the whole country where more than 140 crores are there, and scale is quite high. When we say hepatitis, just a viral hepatitis or other, which we have already said that is alcoholic, which is quite high, and also the other thing which we take through water and food. It's very interesting that almost 20 to 25% of the population is alcoholic, and if you convert in crores, I think it will be around 31 crore or 35 crores of the population having alcohol, and 35% will become, or having the hepatitis. That's a very interesting one. And when we have a injured liver, I think the ability to sustain any kind of infection would not be there. So the virus can create more problem to them. And the problem is alcohol, drugs, and then sex, and then all these things go together. So you have more chances of becoming. So handling this, when we say integrated, you have to have the integrated approach also, which is not happening. If you just focus on viral hepatitis, is not going to solve the problem. And if we take just a viral hepatitis, again, screening, we are talking about that, where the screening is available. Although the national program says that it should be available at the primary health center level and sub-center level, but it is actually not available. Although desire is there, but when we say implementation gaps are many, so the limited access to screening is a big problem. And only we can detect a few infections, not the all type of infections. So plex testing is required, where maybe I think Madam can help, where we can design such kind of test where the multiple virus can be detected. So point of care diagnostic is still not there, and we require more and more very reliable, valid, and cheap tests, which are again not there. We have restricted criteria for treatment, and treatment is also not available. That again a problem. Not every place you'll find the treatment. So yes, in Delhi or Mumbai you can say the treatment is there, but actually it is not there. Then financial barrier is a big problem because it's a very costly affair, whether it is treating of a P or C or any other. So financial barrier which need to be looked into when we talk about the national program. The lack of research in this particular area is also, I'll say that we require more and more, and I think we provide more antiviral drugs which are cheaper and available to larger population. When we say the integration, then the Ayush should not be left, and the Ayush modalities are there where large number of molecules are there, or the drugs are there, hubs are there for them, which can be, become the part of our national program. And the last one is the, our lack of awareness, which is to be increased by the national program. So we have the stigma involved in it. If we screen, then should we are able to treat them or able to provide them the antiviral. If we are not, then we have no rights to screen somebody and label somebody that you are hepatitis B or C or so that become a ethical issue also. But the stigma is attached, whether it's a hepatitis B or C or any kind of infection, maybe the HIV. So they go hand in hand. So the problem is that in most of the things are handled by the program, but the program is financially weak. We require more funding in this program, and state level the PIP should give more funding to such kind of program, which should be in an integrated manner, not just a viral component. That's what I.
So for the audience, Indian comes in intermediate stage of hepatitis B, that is 2 to 4% population is suffering. That is around 6 million, 3 to 6 million people are suffering from hepatitis B. World over, it is around 12 million. And it is the most common reason that people develop cirrhosis and cancer if we leave alcohol. So alcohol is the most common now at the moment, but I think over the time, alcohol is going down. Metabolic and non-communicable diseases are going up. Hepatitis stays there, but because if patient has already alcohol and fat, so he will develop HCC or liver cirrhosis 5 to 10 times faster. So I'll come to my colleague who is on the other spectrum of, because he was from the prevention side and he's on the cure side, it's Dr. Manoj. So where do you think we have missed opportunity to treat patients who have been suffering with hepatitis B and cirrhosis?
Yeah, correctly said. We also, as a surgeon, as a liver transplant surgeon, I also don't want to, go to that extreme. But yes, where we miss to start with, as we know, as our neonatologist said, at birth, at that golden hour, at that golden 24 hour, we are missing that part. We are missing when patient come to us and they are asymptomatic and we are not having any screening facility. We are missing before surgery if we are taking up those patients and we are not doing testing. So we are missing on that aspect. So yes, as Dr. Saab already told, like liver is that beautiful organ, it affect very late, symptoms usually comes very late. So once the cirrhosis develop, the symptoms usually come late. So that's why, prevention is always better than cure.
So that's, yes, sir. So that shows us that detection which is late has enormous burden as well as financially as well as on this one. So Dr. Gopal, so what you have heard about from all three type of experts, so what do you think policy change could bridge these gaps effectively? So, yeah.
Thank you. One of the important things I was just wondering, because we do have a good vaccine which is available, hepatitis B vaccine. We do have a national program, national viral hepatitis control program. Lot of efforts are there. We do have generic medicines. We have good diagnostics. But what is the thing which is missing? That's the question. We are not constrained by the science. We are only constrained by the way things have been implemented. We are having a fragmented implementation system. That's one thing. Fragmented. That means I will be coming to that later. The fragmented system is there. Then we see that after the person is screened, whether the person goes for testing, do we have facilities for testing that person? And after testing, are we able to provide a treatment to that person? These are all the three ecosystems. That means that should be there. To address that issue, I think we should be having a district-centric model. That means the policy should address and build capacities at the district level. That means at the district level, all the things could converge. One of the starting points could be, because we, as I mentioned, that we have good diagnostics, good generics, treatment capacity, and other things. As a starting point at the ARM Center, because of the viral hepatitis program also, the ARM Center, we do have around 1,84,000 ARM Center, which is the basic, erstwhile it is known as the sub-health centers, which caters to a population of 3,000 to 5,000, depending on the terrain which they are having. They do have a nursing practitioner there in the form of a community health officer. He's a nursing graduate. That means the person is able to do point of care testing, but that's one thing. After screening at the sub-center and the primary health center, the district should act as a center for providing the definitive confirmation for that and provide treatment for uncomplicated cases. And the complicated cases can be managed at the medical college. That kind of ecosystem and the paradigm and the flow should be there. That's one thing. This entails the strengthening of the district ecosystem which should be there. Punjab is having a good model wherein for the last, since I think 6-7 years now, they are having a good model wherein they have tried to demonstrate how this from the screening to treatment, from treatment to confirmation, then long-term care is there, and fixing responsibility is there. That kind of ecosystem is there. And the National Viral Hepatitis Program, I think, is having all the things for all these things, for making the things go in the
Thank you. So basically, you have to understand that all patients don't require treatment. Only, you can say, out of if 100 patients are hepatitis B positive, 10-20% will require a medication. 80% can just, they are carriers, they can be managed. So from this, we'll move to the next topic. What we have is vaccination. So I would like a poll from the audience. How many of them in adulthood know their vaccine status? So I think few only. So that's why. So we are not aware about vaccine status. Suppose if we are healthcare workers, we are more exposed. But anybody who may be having a carrier status and develops, God forbid, some problem, like immunosuppression, at that moment, the problem will occur because hepatitis B will reactivate. So I think if you are, just get tested for hepatitis B, and if you are in an immunocompetent state, get vaccinated. So, Dr. Anita, I would to ask you is, does current scientific evidence support expanding, because we discussed of neonatal and pediatric age group, so does it support hepatitis B vaccination in adults and adolescents population, especially high-risk groups?
Yes, definitely. But as you rightly suggested, and the audience also agrees that we are not aware about it, and being a healthcare professional, everybody should be vaccinated. At least in our institute, all those who are working on different viral diagnostics, they are being vaccinated. That's the institute's policy. So it's again a case-based. We cannot have it as a vaccination program, or cannot include, I guess, currently in the vaccination program. But all high-risk people who are dealing with the patients, who are regularly seeing patients. So there has been a data about it, and where it indicates that the vaccination for high-risk population is definitely required, and it is to be implemented. Thank you.
So do you feel that how feasible is universal adult vaccination in India, and do you think it will be successful?
Yes, we already have this universal vaccination for the children, and for the adult, yes, we have problem. We have started the adult vaccination clinic in our preventive health and screening OPD in Safdarjung Hospital, and starting this clinic was a difficult task for us. And having in all medical colleges, maybe all the big health institution in the country, if we can start, it's not difficult, can start this, and I think we can cover large number of, our healthcare work at least. But it should be open to all high-risk group, and also to those which are actually, coming for some other treatment, like in gastro, or maybe in pulmonary and cardiac. The patients are coming and then they can be treated. So we should have an adult vaccination clinic in all the hospitals, particularly the medical colleges. But yes, we have the universal infant vaccination. Catch-up vaccination is there through our Indradhanush mission. So to cover up whatever is left, but by 2030, we'll be able to eliminate. I think it's a difficult task. The time is saying that, please be quick, and still the percentage or coverage of the hepatitis vaccine is very low as compared to other vaccine, and reaching to 90% and above should be the target, but the goals are high, and still the gaps are there. But we don't have a data on healthcare workers and high-risk group, how much are covered, how many people are, immunized. There are many myths and concern, and all these things can be, handled. And such kind of organizations like the Illness to Wellness can generate the awareness about the vaccination to these high-risk group, and even to everybody, that the vaccination is possible and it is available.
Yeah. So basically, high-risk groups as well as people, especially staff, whether they are with the patient or not the patient, should be vaccinated. So I will ask Dr. Manoj, so what are you observing over the last, as you experience clinical, what are you experiencing in HPV-related cirrhosis and liver transplantation? Is the incident varying, improving, or decreasing? What is your in clinical practice?
Yeah, when I started my practice about 15 years back, that time I was seeing the incidence was quite high. But with the kind of treatment available, and now the people are becoming more and more aware. The vaccination programs are rampant. So now the incidences what we are seeing in liver disease and liver cirrhosis, the alcoholic patient we are seeing more often than hepatitis B and C patient group.
Yeah, so same because of the medication as well as awareness. But there are some areas which are like very, you can say, high endemic. So that I think can be targeted. So from policy point of view, what do you think could support adult vaccination program?
I think what I will say that in fact, having an announcement without an unfunded public program is not feasible. We should be going with a phase-wise manner as we are doing currently. That means the zero dose vaccination at the time of birth within 24 hours, and see that the childhood series is completed. So that should be the first priority, and already the UIB program is already taking care of that. Second thing is to focusing on the high-risk individuals like the hospitals and the people who are coming in contact with this. Their schedule should be there. That should be. And third is the people who are exposed, unexposed, and who will be highly vulnerable for that. That kind of approach should be there. Because sustaining the immunization is a big challenge because it takes a lot of finances to sustain any immunization. It has to be shared between the state and the national government. So yeah, that's a big other challenge. But another thing, the third aspect, third tier which I'm talking about is that at least to begin with as a model, the public and the private institutions, they should document the people who are entering the system as healthcare providers. What is their status, and when they are going on, when we are doing a review, and what kind of status they are having. Are they infected or they are protected? That kind of thing there. Otherwise, what I will suggest that we would be going with a phased manner which we are currently doing. So that's the feasible way of doing things.
Yeah, so public partnership you told, because a lot of patients we see in OPD, when they apply for Saudi Arabia or West, so if they turned out to be hepatitis B positive, so they are rejected directly. So they have a policy that any hepatitis B positive patient, they will not, or hepatitis C positive, they will not select. Similarly, I think for all our employment, we should do at least so that we will be doing justice to them. So since the organizers want us to conclude, so I will start one question to each. So ma'am, one myth about viral hepatitis, what do you think could be dispelled?
The myth is about the spread of the hepatitis in case of B and C. Is it spread by having food together, sharing meals and all? So that's the myth which is like all of you are aware of, and the public needs to be educated about it, or there should be awareness about it, about this myth, so that there will be more acceptance about the testing of this hepatitis B as well as C.
So because sometimes patient comes, his viral load is, you can say, more than 10 raised to power 10. So can they share utensils? So will it spread through saliva? Because patient asked us. So because you see all type of, because you do research.
Yeah, it will not.
Yeah.
Because we haven't seen such a kind of cases or reports till now.
So do you test have you tested like patient has a very high viral load, like more than 10 raised to power 15, and salivary specimen or urine specimen?
Yeah, we have tested many, and till now at least the cases which we have screened, we haven't observed such kind of detections. So it's one of the myth which can be taken care of.
So the message is hepatitis B or C doesn't spread through any body secretion other than blood. Yeah. So sir, for you, one public health intervention which you would think and should be implemented in next 2-3 years so that we can the hepatitis B can be taken care of.
Mass awareness. I think with all the, our stakeholders should have the mass awareness about the, problem and in an integrated manner. And that's the most important part. It is not only just viral, but also the alcohol is also equally important. And when we have the two together, then the, infection increases manifold.
So the
it
problem
should be
with alcohol is
combined.
government, that its tax is there. So I discussed with many government policies, so they don't want to discuss that. Because alcohol, until unless, in my, where I work, around my hospital, alcohol shops are more than the medicine shops. So
why you think
yeah.
always, the government has to do this and that? Why not, the public, if they believe that, it should be done in that manner, should, go ahead.
So public will scare them that don't take alcohol. No, now there was a recent Lancet paper. They did all over the
Yes.
world.
Not even
not
a
a single drop
is
useful. Yeah, useful.
So it is already said.
Yeah.
Scientifically, no alcohol.
Yes.
No
So alcohol.
Why, we are not promoting this? Why people are not, going for it?
Yeah. So people say that when we see, we get tempted. It's just like I'm just discussing that. So, Dr. Manoj, any patient population which you want to think that which we overlook, like we miss them again and again, so which we could target?
Yeah, definitely those who are already, on a higher risk side, like those patients who are getting dialysis on regular basis, those we are seeing already the healthcare workers, the person who are in remote areas, like in tribal areas where government is still focusing. So that should be our target population.
And sir, one policy decision you think that could transform the hepatitis program?
One of the important things, I will just answer that before taking my question. Yeah. Because alcohol has been there since civilization, the start of the civilization. That means you have to see that how you negate because it has evolved with that, and all the invasions, other things happened, the cultivation happened because of that. That's a separate debate. Yeah. But the question and the message which you have asked, that means if anybody coming to our system, getting screened, getting tested, he should not go out of the system with a positive report. What exactly right now it is happening, I have screened, the person is having a hepatitis positive report and he is out of the system. See that how the positive report comes into a treatment care plan for him and accountability is fixed. His family members are also prevented against that thing. And we get information from the program for policymakers. That's the three things I think I want to highlight this.
Okay, so with this, I would like to thank the organizers. And we tried to justify the topic, but because of shortage of time, so we are, thanks to my co-panelists and the organizers. Thank you.
Panelists, may I request Mr. Anil Rajput, sir, to please join us on stage for the presentation of Memento. We'll begin with session moderator, Dr. Kapil Dev Jambal, sir, to please step forward. Can we all give it up for our esteemed moderator? We thank him for his able moderation. And now request Dr. Anita to kindly step forward. Kindly keep the applause going. Let's all together thank our eminent speakers, our learned speakers, for sharing their valuable insights and expertise with all of us. Dr. Manoj Gupta, kindly keep the applause going. Thank you very much, sir. Dr. Professor Jugal Kishore. Thank you. Dr. K. Madan Gopal. May I now request all our esteemed panelists to kindly step forward and come together for a group photograph with Mr. Anil Rajput, sir, also joining for the group photograph. Thank you very much. Ladies and gentlemen, we now move towards the concluding session of the day. We once again request you all to kindly remain seated. This is the final session for the conference, and then we'll conclude with a hearty lunch. Kindly remain seated, and we aim to begin in next 30 seconds. Our upcoming session is on From Prevention to Wellness, the role of nutrition and diet in hepatitis care. And as we can see, our stage is all set. Please welcome Ms. Ishi Khosla, Member, Advisory Council, Illness to Wellness Foundation, and Chief Nutritionist, Founder, Celiac Society of India. Dr. Shikha Sharma, Scientific Mentor, Ranfort Wellness. Kindly keep the applause going. Dr. Shabana Parveen, Clinical Nutrition and Dietetics Department, Artemis Hospital, Gurgaon. Dr. Kalpana Vamini Sehra, Senior Ayurvedic Doctor, MD Internal Medicine, Maharishi Ayurveda Hospital. Can we extend a very warm welcome to all our esteemed panelists on stage, and with this I hand over the session to session moderator for further proceedings.
So first of all, my gratitude to Shri Anil Rajputji once again. I think it has been a wonderful journey since the beginning of our association, which is already more than a decade, and we have seen such great programs, and this is another gem in the crown of all the programs that have been conducted by Illness to Wellness. We have heard a lot of information, medical information about the viral hepatitis, their importance, how to prevent and treatment of them. I think we have got a lot of information by now. So I thought, why not do something different in this panel? So how about playing a game with all of us together? Let's start with that, I thought. Maybe let's play this. Initially, I'm going to start with a small interaction with all of you. Let's say something like the fastest finger first. So I would request any one of you amongst the audience to answer a question very briefly in yes or no, very shortly, that I would like to ask. And I think I can request Sandeep ji as a prize to give the first plate to that person when the lunch opens. Okay. So tell me whether it is right medically or not that जिसको जॉन्डिस या पीलिया हो उसको पीले रंग का खाना नहीं खाना चाहिए. फास्टेस्ट फिंगर फर्स्ट. ओके. यस. नो, पीले रंग का खाना नहीं खाना चाहिए. रॉन्ग. दिस इज अ मिथ. ओके. तो जिसको पीलिया जॉन्डिस हो उसको खाली बॉइल्ड खाना खाना चाहिए. मिथ. सो और लोग क्यों नहीं बोल रहे, खाली मैडम ही बोल रही हैं. और गन्ने के जूस से पीलिया ठीक हो जाता है. नो. ग्रेट. आई हैव अ वंडरफुल ऑडियंस. हमें तो कुछ बोलने की जरूरत ही नहीं है. अगर जॉन्डिस हो तो फ्राइड फूड नहीं खाना चाहिए. यस. सो वील कम टू दिस डिस्कशन. दिस इज एक्चुअली आई थिंक अ पैनल वुड एड्रेस दिस क्वेश्चन. अगर किसी को जॉन्डिस हो जाए तो प्रोटीन नहीं खाना चाहिए. नहीं खाना चाहिए. ओके. सो वील एड्रेस दिस आल्सो इन आवर डिस्कशन. अगर किसी को जॉन्डिस हो जाए तो एक्सरसाइज नहीं करनी चाहिए, रेस्ट करना चाहिए, बस खाली आराम करना चाहिए. कितने लोग यस और कितने लोग नो? So this is also a very good issue. We will discuss that exercise is not bad actually, even if there is a jaundice. How about alcohol? Alcohol ले सकते हैं क्या? नहीं. चलिए. इसमें unanimity है. That is really very good. Okay. Okay. So I think we have had a very discussion, and I am really glad that we have a. तो हमारी ऑडियंस बहुत ही जागरूक ऑडियंस है, बहुत जानकार ऑडियंस है. ऐसी ऑडियंस के साथ बात करने में और मज़ा आता है क्योंकि हमें भी बहुत कुछ सीखने को मिलता है. सो फर्स्ट अबाउट आवर लिवर. सो लिवर इज़ द बिगेस्ट सॉलिड ऑर्गन इन आवर बॉडी. लिवर से बड़ा कोई ऑर्गन हमारे शरीर में नहीं है. और आमतौर पे कहते हैं ना बड़ा हुआ तो क्या हुआ, बट लिवर में एक्चुअली उल्टा है. वो बड़ा है और सबसे ज़्यादा काम भी करता है.
So liver is like a huge chemical factory, and it is the central post office, and it is the traffic light, the central traffic light. It is everything into one. जो भी हमारे शरीर के अंदर जाता है, जो भी आप खाते हैं, it has to pass through the liver. So liver does the sorting, liver does the breakdown, liver does the excretion. क्या हमें चाहिए रखता है, क्या हमें चाहिए नहीं चाहिए वो निकालता है. So liver has to take lots of assaults. Liver takes parts literally in everything. आपके immune system में, और विटामिन्स बहुत वाइटल हैं जो लिवर में बनते हैं. लिवर एक बहुत इंपॉर्टेंट स्टोरेज ऑर्गन है जो हमें एनर्जी चाहिए. आप सुबह से इतनी सारी बातें सुन रहे हैं, बैठे हुए हैं, कुछ खा नहीं रहे हैं, तो ये एनर्जी कहाँ से आ रही है? एक्चुअली ये सारी एनर्जी लिवर से आ रही है. तो जब तक आपका लिवर सही है तभी तक आप ये सब कर सकते हैं. एंड वी एंड ऑल टुगेदर आर हैप्पी एंड हेल्थी. सो टुडे वी आर गोइंग टू डिस्कस वेरी इंपॉर्टेंट पार्ट, that is nutrition. The role of nutrition is very important, and when we talk about viral hepatitis, it is second only to antiviral treatment. तो हम सब पहले यहाँ पे क्लियर कर दें कि हेपेटाइटिस बी और हेपेटाइटिस सी जहाँ पे एंटीवायरल थेरेपी या दवाइयों की आवश्यकता है वो तो है ही. जिस चीज़ के बारे में बात करेंगे वो एंटीवायरल ट्रीटमेंट के बाद या उसके साथ साथ आती हैं. रोल ऑफ न्यूट्रिशन. तो सबसे पहले मैं ईशी खोसला मैडम के पास आता हूँ. मैडम, जब एक्यूट हेपेटाइटिस हो जाए, एक्यूट लिवर इंजरी हो, उसके रिजल्ट में अगर जॉन्डिस हो, तो ऐसे में कुछ खास बातों का ख्याल रखना ज़रूरी है क्या?
यस, थैंक यू डॉक्टर राजेश. और ये हम सभी को पता है कि डाइट एक इंटेग्रल पार्ट है रिकवरी का, और जब ये अक्यूट सिचुएशन में होता है तो डेफिनेटली एक कॉमन सेंस है जो रेस्ट कहते हैं, डाइजेस्टिव रेस्ट हमारी बॉडी को चाहिए. आपने अभी बताया कि लिवर एक अपने आप में बहुत काम करने वाला ऑर्गन है, बट जब लिवर ही थोड़ा सा थक गया तो उसको रेस्ट देना बहुत ज़रूरी है. और इसके लिए जो डाइट आप चूज़ करेंगे वो लिटरली एक लाइट डाइट, उबला हुआ ज़रूरी नहीं है बिल्कुल, दैट्स अ मिथ, लेकिन जो खाने में पचाने में आसान हो, नंबर 1, फ्री ऑफ केमिकल्स एंड प्रोसेस्ड इंग्रेडिएंट्स. तो बाज़ार का खाना बिल्कुल नहीं. और जो आप अपनी जो इंग्रेडिएंट्स हैं वो ऐसे हों जो आप ईज़िली डाइजेस्ट कर पाएँ. चाहे वो अनाज क्यों ना हो, आप खिचड़ी की बात करें, दाल चावल की बात करें, इजी टू डाइजेस्ट वेजिटेबल्स, और उसमें जो फैट यूज़ करें, स्पाइसी ऑफ कोर्स नहीं होना चाहिए बहुत ज़्यादा, बट हल्दी का इस्तेमाल ज़रूर करें. और जो फैट्स परमिटेड हैं इस सिचुएशन में, जो हमारी बहुत ज़रूरी इसलिए हैं क्योंकि उससे कैलोरीज़ बनती हैं. जब हमारे शरीर में ऐसा आती है कोई सिचुएशन जहाँ पे रिकवर करना है, रीजेनरेट करना है डैमेज सेल्स को, तो सबसे मोस्ट इम्पॉर्टेंट थिंग इज़ एडिक्वेट कैलोरीज, है ना. तो वो पूरी, अगर हम हल्का खाएंगे और वैसे भी भूख नहीं है तो थोड़ा सा खाना वैसे ही कम हो जाता है. तो उसके लिए जो गुड फैट्स हैं वो ज़रूर इस्तेमाल करें. वो गुड फैट्स कौन से हैं? जैसे शॉर्ट चेन फैटी एसिड्स. शॉर्ट चेन फैटी एसिड्स को बहुत ज़्यादा टाइम नहीं लगता बॉडी को डाइजेस्ट करने में. तो मक्खन हो गया, घी हो गया, और इस किस्म की जैसे कोकोनट ऑयल है, ऐसे फैट्स को इस्तेमाल करें. बहुत ज़्यादा रिफाइंड ऑयल और जो पॉली अनसैचुरेटेड फैट्स हैं उनको ना इस्तेमाल करें. और इवन क्रीम, जो डेयरी फैट्स हैं वो भी आप ले सकते हैं, जिससे आपकी बॉडी में कैलोरीज भी जाएंगी और गुड फैट्स जाएंगे, जिससे आंतें भी हमारी इम्प्रूव करती हैं, उसको सपोर्ट मिलती है. सो अल्टीमेटली जो दो बातें हैं, एक तो डाइजेस्टिव रेस्ट एंड ऑल्सो गट फ्रेंडली एंड गट हीलिंग, गट सपोर्टिंग. सो इससे जो उठती है, लोग कहते हैं हम दही खाएं. यस, ज़रूर खाएं दही, बट वो दही जो है वो प्रोबायोटिक का काम नहीं करता. आपको प्रोबायोटिक सप्लीमेंट्स की भी ज़रूरत होती है. सो वो भी आप अंडर सुपरविजन लें, जिससे आपको सपोर्ट मिले एंड आपकी बॉडी जल्दी हील करे. एंड एक मुद्दा आपने उठाया था रेस्ट का, तो रेस्ट करेंगे, ज़रूर करें, बेड रेस्ट नहीं, लेकिन डेफिनेटली अपनी बॉडी को रेस्ट करेंगे मेंटली एंड फिजिकली, डाइजेस्टिव रेस्ट ऑफ कोर्स, एंड फिजिकल रेस्ट एंड डिजिटल detox also is important for your body to recover. So ये कॉमन सेंस बातें हैं, कोई बहुत ज़्यादा इसमें सोचने की बात नहीं है, लेकिन फैट को लेके बहुत मिथ्स हैं, इसलिए अच्छा है कि आपने ये सवाल उठाया.
Thank you, ma'am. Thank you. So what happens is, since we are talking about hepatitis and specifically viral hepatitis, so they can be acute stages of hepatitis B, hepatitis C, and we have heard in the very beginning also about hepatitis A in adults, and that we are seeing quite often, frequently in our clinics, that we have adults and coming with hepatitis A, and they definitely are very severe. So जो acute hepatitis की फेज़ होती है वो होती है जिसको आमतौर पे हम लोग जॉन्डिस बोलते हैं, जब पीलापन आ जाता है, ये जब खाना नहीं खाया जाता है, जी मिचलाता है, उल्टी आती है, डिहाइड्रेशन, तो ये सब जो ऐसी जब अवस्था आ जाती है तो वो एक्यूट फेज़ होती है बीमारी की. लेकिन वो एक्यूट फेज़ होने का भी ये मतलब नहीं, जैसे मैडम अभी बता रही थी कि आप कुछ सॉलिड खाना ना खाएं, या खाना ऐसे में हानिकारक हो सकता है, या ऐसे में पीली चीज़ें या हल्दी ना खाएं. सो इवन इन दिस फेज ऑफ एक्यूट हेपेटाइटिस, फूड should be given and adequate nutrition should be given. But there should be certain concerns कि क्या चीज़ कैसे खाएं और कैसे उसका ध्यान रखें. The other thing is there is a condition called cirrhosis or liver failure. So that is a different condition which requires medical nutrition therapy. उसमें nutritional requirements change हो जाती हैं और ये भी important होता है कि किस तरह से खाना दिया जाए. So Dr. Shikha, I would like to come over to you from your medical experience. So in these two stages, because we have very little time, that's why I'm taking both these together. What is your recommendation about nutrition to listeners? क्या कहना चाहेंगे?
So liver cirrhosis and liver active failure जब होता है, तो एक चीज़ हमें याद रखनी है, liver cirrhosis में liver का structure डैमेज हो रहा है, उसकी दीवारें डैमेज हो रही हैं, तो उसमें फाइब्रोसिस हो रही है, यानी कि लिवर अब परमानेंटली जो काम करने में उसकी क्षमता कम हो रही है. दैट इज़ वेरी इंपॉर्टेंट टू डिस्टिंग्विश. व्हेन वी हैव एक्टिव हेपेटाइटिस हैपनिंग, तो हमें ये समझना है, एंड आई विल क्विकली टेल यू सम पॉइंट्स एंड देन आई टेल यू सम इंटरेस्टिंग पॉइंट्स, सम फन पॉइंट्स. जब एक्टिव लिवर में इन्फेक्शन चल रहा है तो लिवर क्या कर रहा है, उस इन्फेक्शन को फाइट कर रहा है थ्रू प्लेटलेट्स, थ्रू फाइटर सेल्स. तो हर एक सेल भरा हुआ है पस से, उसके अंदर फाइटर सेल्स हैं, उसके अंदर पस है. सो फर्स्ट थिंग, मोस्ट इम्पॉर्टेंट, हाइड्रेशन, साफ पानी, बिकॉज जितना पानी पिएंगे, जितना आपका सर्कुलेशन बढ़ेगा, उतना द लिवर कैन क्लीन ऑफ इट सेल्फ. हीलिंग कौन कर रहा है? वन थिंग विच आई मस्ट टेल यू, एंड डॉक्टर केसरी इज विद मी हियर, हम डॉक्टर हैं बट रियल डॉक्टर बॉडी है. The body is going to heal itself. We are only as assistants to the body. This is a very important thing. I would want everybody to take the message कि हम जो शरीर है, शरीर मेन डॉक्टर है. We are assisting the शरीर to heal itself. अब how do we assist the शरीर to heal itself? The first thing, like I said, hydration very important, clean, hygienic food and water. And जैसे मैडम मिशी खोसला जी ने बोला कि no preservatives, no chemical. कई लोग कहते हैं ऑर्गेनिक बहुत महंगा है. आपकी लाइफ से ज़्यादा महंगा नहीं है. दिस इज़ द टाइम टू ईट ऑर्गेनिक, बट अगेन यू हैव हाइजीनिक फूड. उसमें कौन कौन सी चीज़ें जो आयुर्वेदिक आहार में लिखी गई हैं, जैसे उन्होंने कहा खिचड़ी पुराने चावल की, नए चावल की नहीं, मूंग दाल के साथ. सेकेंड थिंग, जैसे हल्दी है, वेरी गुड. गरम मसाला नहीं यूज़ करना, बिकॉज इन आयुर्वेद दिस इज कॉल्ड अ पित्त फायर डिसऑर्डर. तो गरम मसाला नहीं, यू हैव टू हैव नरिशिंग फूड. जितने भी हमारे नरिशिंग होते हैं, जितने बॉटल गोड्स हैं, पम्पकिन है, जितने भी हैं, उसको आप घी में बना सकते हैं. बट व्हाट इज़ वेरी इंटरेस्टिंग इज, एंड आई वाज जस्ट सर्चिंग बिफोर कमिंग हियर, कि घी बेटर कि बटर बेटर. एंड आई वाज थिंकिंग शायद बटर बेटर होना चाहिए, हल्का है. नो, घी इज़ बेटर, because butter is heavier to digest according to Ayurveda. So that was very interesting for me also when I was researching coming here. देन व्हाट इज़ इम्पॉर्टेंट इज़ क्योंकि इसको फायर डिसऑर्डर कहा जाता है, तो कोकोनट वाटर जिसकी तासीर ठंडी है, सूप्स, बट सूप्स आप कहेंगे वो गर्म है बट उसकी तासीर ठंडी होती है, डिपेंडिंग, जैसे आप जौ का सूप पी रहे हैं, बारले का सूप पी रहे हैं, आप अदरक डाल रहे हैं, अदरक इज़ व्हाट, अ डाइजेस्टिव, आम पाचक. आम पाचक मीन्स कि इट्स गोइंग टू डाइजेस्ट ऑल द टॉक्सिन्स ऑल्सो. सो वो आम पाचक जो है वो अदरक आप डाल रहे हैं. सो सूप्स हो गया, खिचड़ी हो गई, कोकोनट वाटर हो गया, फल, ऑर्गेनिक फल. पुराने ज़माने में व्हेन यू कुड गेट हाइजीनिक शुगर केन भी जूस कहा जाता था, बट अब हम नहीं कहते बिकॉज कोई घर में नहीं बनाएगा और बाहर बाजार से लाएंगे विच इज़ फुल ऑफ इन्फेक्शन. सो हम मना करते हैं. दैट इज़ द प्रैक्टिकल प्रॉब्लम विच वी फेस टुडे. सो वो मना किया जाता है. नाउ व्हाट इज़ वेरी इंपॉर्टेंट इज़ कुछ चीज़ें जो शायद फूड से कनेक्टेड नहीं है. लिवर का एक आपने शायद शब्द सुना होगा, ना, जस्ट टेक 10 सेकेंड. जिगरी दोस्त. जब पहली बार मैंने ये शब्द सुना जिगरी दोस्त, तो मुझे समझ नहीं आया कि जिगर का मतलब क्या है. मुझे लगा दिल होगा, जिगर का मतलब तो लिवर है, तो लिवर का दोस्त क्या होता है, लिवरी दोस्त. आई कुड नॉट अंडरस्टैंड. देन आई वेंट इनटू आयुर्वेद एंड अंडरस्टूड जो आपका लिवर है, इट इज़ नॉट ओनली प्रोसेसिंग फिजिकल फूड, इट इज़ ऑल्सो प्रोसेसिंग इमोशनल फूड. अगर आप नाराज़ हो रहे हैं, अगर आप एंग्री हैं, अगर आपके अनरिजॉल्व इमोशंस हैं, आपका लिवर डैमेज होगा, बिकॉज लिवर इज़ ऑल्सो द प्लेस वेयर यू ट्रांसम्यूट अनरिजॉल्व इमोशंस इनटू रिजॉल्व इमोशंस. And that is very important. And if you really connect the dots, जब इंसान परेशान होता है तो वो जंक फूड खाता है, और परेशानी उसकी एक तो इमोशंस अनरिजॉल्व हैं जो लिवर के थ्रू जा रही हैं, दूसरा फिर आप खाना भी वही चूज़ कर रहे हैं विच इज़ नॉट गुड फॉर योर लिवर. सो इट्स वेरी इंपॉर्टेंट टू टेक अ होलिस्टिक व्यू ऑफ योर लिवर हेल्थ, बिकॉज जिगरी दोस्त मतलब दोस्त आपका अगर अच्छा है तो आपके जिगर को हेल्दी करेगा, अगर दोस्त आपका खराब है तो आपके जिगर को वो भी हार्म करेगा. सो मेक श्योर यू हैव गुड फ्रेंड्स अराउंड यू, गुड पीपल अराउंड यू.
Definitely, that was really very interesting. And in fact, I would add to it कि जिगर ही आपका सबसे अच्छा और सबसे जिगरी दोस्त है, क्योंकि जो काम जिगर आपके लिए करता है आपके लिए कोई और नहीं कर सकता. आपका जिगर जो है एक पूरी केमिस्ट शॉप है जो इतनी छोटी सी जगह में आपके शरीर के अंदर में जितने बड़े बड़े विटामिन हैं, विटामिन ए, विटामिन डी, विटामिन के, विटामिन ई, ये सब लिवर में बनते हैं. तो जब आपका लिवर थोड़ा बीमार हो जाता है, ये सब बनने कम हो जाते हैं, तब हो सकता है आपको सप्लीमेंटेशन लेना पड़े. आयरन जो है, जो हमारी हीमोग्लोबिन है, उसकी शॉर्ट लाइफ, उसकी लाइफ ज़्यादा नहीं होती. तो जो बिलिरुबिन जो बनता है, जिसको हम पित्त बोलते हैं एक्चुअली, वो हमारा खून ही होता है. तो उसको नष्ट करके उसको शरीर के बाहर निकालता है, नया खून बनता है. इस सब में लिवर का, जिगर का बहुत ही इम्पोर्टेंट रोल है. हमारा इम्यून सिस्टम एक्चुअली जो एंटीबॉडीज़ हैं बहुत सारी, वो हमारे लिवर से बनती हैं. कोलेस्ट्रॉल, जो कोलेस्ट्रॉल का रेगुलेशन है, वो सारा हमारे लिवर में बनता है. हम जो भी खाते हैं, अक्सर आप लोग बोलते हैं, डॉक्टर के पास आते हैं कि डॉक्टर साहब मैं तो कुछ खाता नहीं, मेरा कोलेस्ट्रॉल क्यों बढ़ा है, मेरा LDL क्यों बढ़ा है? क्योंकि आपने खाया नहीं. आपने जो भी खाया था, लिवर ने उसको सबको तोड़ दिया और उससे नया कोलेस्ट्रॉल जनरेट किया. तो ये काम भी लिवर कर रहा है. बहुत सारे हार्मोन्स हैं जो लिवर बनाता है. अभी जो मैडम ने स्ट्रेस की बात की, तो वो जो स्ट्रेस के हार्मोन होते हैं, ख़ासतौर पे कॉर्टिसोल, वो लिवर के ऊपर ऐसा असर करते हैं कि उसके अंदर फैट जमा होता है. जब हम खाना खाते हैं, हम कुछ भी मीठा खाते हैं, हमें लगता है हमने मीठा खाया, एनर्जी में जल गया, हमने जला दिया, ख़त्म हो गया. ऐसा नहीं होता, क्योंकि वो मीठा फैट में कन्वर्ट होकर आपके लिवर में स्टोर होता है और आपके लिवर को हानि पहुंचाता है. तो मैं शबाना जी से पूछना चाहूँगा कि ये एक मिथ जो बहुत सारे लोगों ने बोला कि अगर जॉन्डिस है, ये हेपेटाइटिस है, तो बहुत मीठा खाना चाहिए. आजकल MASLD या फैटी लिवर की वैसे ही बहुत सारी प्रॉब्लम है. तो पहले तो बताइए कि मीठा खाने से लिवर को फ़ायदा होता है क्या? हेपेटाइटिस में ज़्यादा खाना चाहिए, इज़ दैट ट्रू? और इफ़ किसी को फैटी लिवर भी है और हम ऐसा करते हैं तो उससे नुकसान हो सकता है क्या?
सो आई थिंक ऑलरेडी हमारा जो पैनल डिस्कशन है एक बहुत ही अच्छी डायरेक्शन में आपने. हेलो, इज इट ओके? हेलो.
सो आई थिंक हमारा पैनल डिस्कशन ऑलरेडी एक अच्छी स्टार्टिंग से सही डायरेक्शन में लेके गए हैं डॉक्टर राजेश, थैंक यू एंड ऑल द पैनलिस्ट। सो अब हमारा लीवर जो है वो ठीक से वर्क नहीं कर रहा है और क्वेश्चन ये है कि अब हमें मीठा खाना चाहिए या नहीं खाना चाहिए। सो मीठा ऑफ कोर्स हमें नहीं खाना चाहिए। उसका पहला आंसर जैसे डॉक्टर राजेश आप ऑलरेडी अभी दे ही चुके हैं कि अगर आप मीठा खा रहे हैं तो वो पचेगा नहीं, अभी डॉक्टर शिखा ने भी जैसे हमें बताया है, और वो कन्वर्ट होगा फैट में। और आगे हम इससे कनेक्ट कर रहे हैं, फैटी लीवर को भी ट्रीट करने की बात कर रहे हैं। तो मैं एक सिनेरियो लेना चाहती हूँ जैसे कि जो मैं आपको आसान तरीके से समझा सकूँ कि एक पर्सन है जो ऑलरेडी ओवरवेट है और धीरे धीरे करके वो ओवरवेट अगर वो ठीक नहीं होगा तो वो ओबेसिटी की कंडीशन में लैंड अप हो जाएंगे। ठीक है, वहाँ पर ही फैटी लीवर की कंडीशन भी है जो कि बहुत ही ईजिली एसोसिएट हो जाएगी। और अब अगर हम मीठा खाएंगे तो ऑफ कोर्स हमारे जो लीवर है उसको मेटाबॉलिक रिस्क बहुत ज़्यादा हो जाएगा। सो मैं क्लिनिकली इस चीज़ को मतलब डिस्कस करना चाहूँगी। यूजुअली जब हम ओपीडी में पेशेंट्स देखते हैं राइट, उनको आजकल मोस्टली पेशेंट्स फैटी लीवर के साथ में आते हैं। ग्रेड 1 फैटी लीवर बहुत ही ज़्यादा कॉमन हो गया है एंड अवेयरनेस की, एजुकेशन की बहुत ज़्यादा ज़रूरत है और मिसलीडिंग इन्फॉर्मेशन जो लोगों के पास है उसको करेक्ट करने की बहुत ज़्यादा इन्फॉर्मेशन ज़रूरत है। So normally when I receive patients in my OPD, we talk about and we encourage them to eat a healthy balanced diet. That is the simplest way what we can do for us on a daily routine. Now what is balanced diet? I think इसको बहुत ज़्यादा टफ नहीं समझना चाहिए कि अगर हम किसी डाइट को फॉलो करेंगे तो उसमें हमें बहुत ही कोई फैंसी फूड्स ऐड करने की ज़रूरत होगी और तभी हम अपनी हेल्थ को बहुत अच्छी तरीके से देख सकते हैं। अगर हम सिंपल फूड ग्रुप्स की भी बात करें जिसमें कि बैलेंस डाइट की मैं बात कर रही हूँ, होल ग्रेन सीरियल्स हैं, कॉम्प्लेक्स कार्बोहाइड्रेट्स हैं, सीजनल फ्रूट्स, सीजनल वेजिटेबल्स, हेल्दी फैट्स की जैसे कि मेरे अदर रिस्पेक्टेड पैनलिस्ट बात कर रहे थे, हेल्दी फैट्स को इनकॉर्पोरेट करने की बात करें। और एंटीऑक्सीडेंट्स विल बी you'll receive the antioxidants by eating the colored rainbow seasonal fruits and vegetables. Along with that, good amount of physical activity, as much as it possible, at least 30 minutes, 40 minutes का physical activity. एंड इससे प्रीवियस डिस्कशन जो चल रहा था हमारे पैनल डिस्कशन से पहले जिसमें हम अल्कोहल की बात कर रहे थे, सो कंप्लीट नो अल्कोहल। सो आई थिंक सिंपल वेज और सिंपल चीज़ों से भी हम अपनी हेल्थ को अचीव कर सकते हैं। And of course, sugar is absolutely not good. I encourage my patients to avoid ultra-processed foods, sugary drinks, all those sealed, canned, packaged food items because इसमें simple carbohydrates हैं और it is a very bad quality of fat is being used there. So this is what it is. This is my answer.
Yes, very true. Completely agree with you. Thank you so much. Dr. Kalpana, I would like to ask you, from the point of view of Ayurveda, I would request some very specific advice that from our daily choices of what we have in our kitchens. Could you give some suggestions, some advice that these are good or these should be avoided in a person who's having hepatitis or liver or suffered from some liver injury?
यस, मोस्ट डेफिनेटली, बट उससे पहले मैं एक जैसे आप आयुर्वेदा को और समझ पाएँ, सो दिस इज़ दिस कॉन्सेप्ट इन आयुर्वेदा दैट रोगः सर्वे अपि मंदग्नौ, एंड आई प्रॉमिस दिस इज़ द ओनली संस्कृत आई एम गोना यूज टुडे। सो दिस इज़ कि हर रोग जो है आपका मंद अग्नि से शुरू होता है। सो अग्नि इज़ अ कोर कॉन्सेप्ट इन आयुर्वेदा टू ट्रीट प्रिवेंट एनी डिजीज़। सो जब तक आपकी अग्नि, और ये अग्नि सिर्फ डाइजेशन नहीं है, ये आपके पेट का डाइजेशन और अब्जॉर्प्शन नहीं है, ये आपके सेल एंड टिश्यू लेवल के मेटाबॉलिज्म भी है। सो सबसे पहला, टू प्रिवेंट हेपेटाइटिस और प्रिवेंट एनी डिजीज़ यू नीड टू टेक केयर ऑफ योर डाइजेशन। एंड इसके लिए आयुर्वेदा जो है आपको काफ़ी चीज़ें बताता है। फर्स्ट एंड फॉरमोस्ट अगर मैं सिर्फ हेपेटाइटिस के लिए बात करूँ तो एक्यूट इन्फ्लेमेटरी स्टेज में अलग और क्रॉनिक में अलग बात की जाती है। तो बिल्कुल सही, ये एक पित्ता डोमिनेंट डिजीज़ है. सो पित्ता इज़ जनरली द फायर ऑफ द बॉडी. अगर मैं बहुत सिंपल लैंग्वेज में इसको बोलती हूँ तो जब एक्यूट स्टेज होती है और पित्ता आपका काफ़ी हाई होता है, इन्फ्लेमेशन बहुत हाई होता है, तो मतलब एक्टिव डैमेज टू हेपेटोसाइट्स हो रहा है. यू वांट टू अवॉइड फाइब्रोसिस आगे जाके. तो इस टाइम पर आप सबसे बिल्कुल सही कि लाइट ईजिली डाइजेस्टेबल फूड देना चाहिए, जिसमें हम बार्ली वाटर बहुत यूज़ करते हैं. सो बार्ली फर्स्ट एंड फॉरमोस्ट ये इजी टू डाइजेस्ट है. ऑल्सो ग्लूकागोन रिजर्व को भी हमारे लिवर के पूरा करता है. तो बार्ली वाटर अगेन हाइड्रेशन को भी पूरा कर रहा है एंड थोड़े कार्बोहाइड्रेट्स दे के हमें एनर्जी भी दे रहा है. सेकेंड इज स्प्लिट मूंग दाल, ग्रीन मूंग दाल, गुड लाइट सोर्स प्रोटीन का है, एनर्जी देगा एंड वेरी लाइट टू डाइजेस्ट है. तो एक्यूट स्टेज में हम ये दे सकते हैं. अगेन इट इज़ अ वेरी हाई पित्ता कंडीशन, एक्यूट इन्फ्लेमेशन. तो इस टाइम पे कूलिंग वेजिटेबल्स, कूलिंग खाने की चीज़ें देना, जैसे कि ऐश गार्ड है, बिटर गार्ड है, स्नेक गार्ड है. सो वी से बिटर इज़ बेटर ऑलवेज. सो सारी ये चीज़ें बिटर जो है हम ज़्यादा देते हैं. कोकोनट वाटर है एंड सम ईजिली अवेलेबल आयुर्वेदा फॉर्मुलेशंस भी हम देते हैं, जैसे भूमि अमल की है, यष्टि मधु है, यष्टि मधु इज़ योर मुलेठी. तो ये सब हम शुरुआत में देते हैं. एंड जब क्रॉनिक हेपेटाइटिस की बात आ जाती है, यानी फाइब्रोसिस हो चुका है, तो वी आर वेरी केयरफुल कि, और जब क्रॉनिक हेपेटाइटिस है तो डेफिनेटली सार्कोपीनिया के चांसेस होते हैं, एक्टिव मसल लॉस, मसल वास्टिंग के चांसेस होते हैं. तो येस, पहली चीज़, प्रोटीन इज़ नॉट बैड इन हेपेटाइटिस. वी आर नॉट अगेंस्ट प्रोटीन, बट अगेन डाइजेशन पर आपके ज़रूर ये डिपेंड करता है. इफ़ यू हैव वीक अग्नि, यू आर नॉट एबल टू डाइजेस्ट, फिर हम आपको प्रोटीन नहीं देंगे. और इन केसेस अगर आपको या फिर अ पेशेंट इज़ गोइंग थ्रू या फिर चांस है या रिस्क है ऑफ हेपेटिक एन्सेफेलोपैथी, तो हम वहाँ पर नहीं एडवाइस करते हैं. अदरवाइज सिंपल प्रोटीन आइसोलेट्स, प्लांट डिराइव्ड, ग्रीन मूंग, ये ज़रूर दिया जाता है सार्कोपीनिया अवॉइड करने के लिए. सेकेंड इज़ हम उनको फैट्स ज़रूर देते हैं, स्मॉल माइक्रो डोजेज ऑफ ईदर A2 काउ घी, कोल्ड प्रेस ऑयल्स, सीड ऑयल्स हम हमेशा मना करते हैं. ये थोड़े थोड़े अमाउंट में देना बहुत ज़रूरी है, बिकॉज नाउ न्यूट्रिशन काफ़ी लॉस हो जाता है बिकॉज ऑफ लॉस ऑफ एपेटाइट एंड वॉट नॉट. तो इस टाइम हम चाहते हैं कि जो हमारे फैट सॉल्युबल वाइटामिन्स हैं ADE, इसको एक, ये लाइपोफिलिक हैं, ठीक है, लाइपोफिलिक हैं, तो इनको चाहिए फैट मीडियम. देन दिस इज़ ऑल्सो रिकमेंडेड. एंड ड्यूरिंग एंटीवायरल थेरेपी ऑल्सो हम रेकमेंड करते हैं कि आपके गैस्ट्रिक म्यूकोजा को बचाने के लिए यू नीड हेल्दी फैट्स. तो यष्टि मधु, हेल्दी फैट, इट इज़ एडवाइज्ड इन दिस टाइम.
Thank you, thank you. And I think once again we should all understand that when we are talking about nutrition and when we are talking about other things also, that whatever advice the doctor is giving and whatever medication or prescription the doctor has given are a must and they are no substitute. They should be taken only along with the nutritional advice. Yes, it happens that people with hepatitis, especially with acute phase of hepatitis, they become weak and they have muscle loss leading to sarcopenia. So protein supplementation in such patients is very highly recommended. इसीलिए प्रोटीन लेना ज़रूरी है, वो प्रोटीन जो एक्सेप्टेबल हो, जो इजीली डाइजेस्टेबल हो, और मैडम ने उसके बहुत अच्छे food based, and it is true that plant based proteins are better accepted than animal proteins. But I, as a doctor, have seen some things in my practice which I want to bring out here, and from this platform I would reiterate and I would request all of us to give this message to the listeners also, that there is no one-shot treatment for these different hepatitis. अक्सर क्या होता है कि जब हेपेटाइटिस होता है, जॉन्डिस होता है, so there is a notion कि आयुर्वेदिक कोई सिरप, दवाई, चूरन, पाउडर, there are so many of them available that every chemist would give 10 of different boxes, so patient comes, वो ये भी ले रहे हैं, ये भी ले रहे हैं, ये भी ले रहे हैं. So I would start with you, Shiva. Are such supplements advisable? What do you say about that?
I think it's an opportunity to talk about the whole mania about protein these days. and the absolutely unrealistic recommendations made, I don't know where they're coming from, calculations being done, and powders are being added. And I think I will use this forum to tell everybody who's listening that these ultra-processed protein powders, even if they are made from plant protein, are not really desirable. And they, in fact, can have an opposite effect on the liver and increase liver enzymes, increase CRPs, which is a marker of inflammation, and many other, of course, consequences because of this. So I think the diet is your best friend. If you do want to add protein, be very judicious, and only when it is warranted. We are all feeling very sorry, and we are equating sarcopenia with intake of protein. It doesn't work like that. Sarcopenia is muscle loss. You have to use your muscles. You have to do resistance exercises for muscle to be built. It will not happen if you start consuming large amounts of protein, which is actually not stored in your body if it is in excess. It is only draining your liver and your kidney and being stored ultimately as sugar and fat. So please be very mindful. अगर आपने sarcopenia को address करना है, तो आपने अपनी gut पर जाना है. Gut पे अगर आपकी absorption पूरी नहीं हो रही, तो वो पहुँचेगा ही नहीं muscle तक, and it will be detrimental. So please, the path is very clear, and excess proteins and protein supplements should be very, very carefully addressed. And if possible, if you need to and you're convinced that you require it, make sure it's through natural dietary sources and good sources. Even if you're taking animal protein, it should be clean protein. So I think I'll leave it at that.
So the question was about the supplements, because this is a big problem with population in general. People have problem, they go to the chemist shop and they buy supplements and syrups for the liver, and they think it is good, so which actually is not. So I want each of you to reinforce this fact so that the message goes through.
You're absolutely right. These should be done under medical supervision only. There are lots and lots of syrups available. I don't want to name anyone, but certainly if your doctor thinks it's necessary, he will prescribe it. Else, you also need to look out for certain critical nutrients, particularly vitamin D and vitamin C, etc. So please do your checks. B12 also is low when you have a liver issue. So you need these supplements, but don't self-medicate yourself. Don't supplement on your own. Seek guidance for that. They are important, but they should not be taken on your own. That is my message.
Because many of the so-called supplements and liver tonics, they contain heavy metals which actually are detrimental and injurious. Would you like to add?
Absolutely.
So let's start very simply. आम तौर पे मैंने देखा है कि पेशेंट कहता है, मैडम मैंने इंस्टाग्राम में ये देखा था और वो इंस्टाग्राम इन्फ्लुएंसर ने कहा ये खा लो, राइट? व्हेन यू गो टू अ डॉक्टर यू से ये एमडी है, ये डीएम है, क्या क्वालिफिकेशन है? बट स्ट्रेंजली हम खाने पीने की चॉइस के समय इंस्टाग्राम की किसी एआई जनरेटेड वीडियो को ट्रस्ट करते हैं. माय फर्स्ट humble suggestion, please don't start following a diet based on some AI video of Instagram. It is unscientific and it has no basis. Second thing, जितने भी आप supplements market में देख रहे हैं, it is half information. In Ayurveda, there is a concept, and I'm sure doctor will reiterate, कि आपको जो भी खाना है आपकी बॉडी की नेचर, बेसिकली इट्स लाइक अ डीएनए, और प्रकृति की नेचर के अकॉर्डिंग खाना है. सो व्हाट विल सूट Dr. Kesri will not suit me, will not suit her, which means कि it is basically a DNA mapping. अब ये चीज़ लोगों को पता नहीं होती. वो आयुर्वेद की इंस्टाग्राम के किसी इन्फ्लुएंसर से कहते हैं कि ये खाना है, तो सीधे फ्रॉम इंस्टाग्राम दे गो टू Amazon, buy. So what I'm trying to say is that food is one of the most sophisticated sciences, and food has very powerful healing power. If you misuse food, you can damage, which means कि अगर आपने supplement randomly खरीद लिया, just because you like the color of the box, or some Instagram fellow told you कि ये बड़ा अच्छा है, आप खा लो, मैंने खाया, मेरी muscle double हो गई. That's not the way to choose supplements. The choice of supplements has to be evidence-based, scientific, and it has to match your body and your disease condition. So whenever you are choosing supplement, apply the same rigor as you do when you are eating a medicine. Number 3, many of the supplements don't have adequate dosage only. अगर आप supplements को देखें, कई supplements जो ऐसे randomly बन रहे हैं with some strange manufacturers, जिसका नाम भी आपने कभी नहीं सुना, उसमें dosage ही adequate नहीं है. So what are you going to do with those supplements? Many of them have artificial chemicals and flavors which you don't need in your life, especially if you have hepatitis. So what I'm saying is हम supplements कई बार सिर्फ एक सुंदर बॉक्स के कवर पैकेजिंग को देख के खरीदते हैं या किसी इंस्टाग्राम वीडियो से देखते हैं. प्लीज बी मोर केयरफुल when you're choosing a supplement. Consult your dietitian, consult your doctor before you buy a supplement. That's my only thing I would say, because all supplements are not the same and of the same quality, or even the supplement which works for me may not work for her.
Thank you, ma'am. That's very true. I would just like to add one thing here, that, you know, even though we are talking about viral hepatitis right now, there are other non-communicable diseases which may ultimately, like fatty liver, MASLD, which is now it is called, which might lead to chronic inflammation in liver and then cirrhosis. So, but now, since past 1 year or so, there have been agents introduced which we are actively using and which can be very beneficial. So one thing you all must remember is you have to go back to your doctor, tell your problem and seek the best possible treatment, because treatment now is available for such conditions as well. Since we are running short of time, I would request all of you to give message to our audience, how to make your liver more resilient, how to fight disease, and tell us about some things which are easily, readily available, and things which can be implemented. This is most important. We talk about a lot of things, but we can hardly use them in our lives. So please give your message using what is there in our homes, in our kitchens, things that we can do. Huh? Yes, sure.
So I have a very simple message. Every day have a smoothie which has apple, beetroot, carrot, ginger, amla. That is my simple way how I look after my liver and my health.
So I would like to talk about the balanced diet only, because अगर हम basic follow कर सकते हैं तभी हम long term में अपनी health को अच्छा देख सकते हैं. अगर हम इधर उधर से, जैसे भी सारे ही पैनलिस्ट में कई सारी बात करी, सप्लीमेंट्स की बात करी, सार्कोपीनिया की बात करी, फिजिकल एक्टिविटी की भी बात करी, अभी सार्कोपीनिया की जैसे बात हो रही थी, तो जब आप प्रोटीन ले रहे हैं और फिजिकल एक्टिविटी कर ही नहीं रहे हैं तो आप मसल गेन कैसे करेंगे. सो आई थिंक बहुत ही सिंपल चीज़ें हैं जो करने की ज़रूरत है. So we can eat our fresh food, home cooked food. We can avoid as much as possible from the outside food. We can, get into our daily routine physical activity, that whatever the minimum that you can make it. So that's my simple message to everyone.
Thank you, thank you. Dr. Kalpana.
So my message will be to eat with the sun. So जब आपका sun सबसे highest होता है, you take your biggest meal at that time, and then gradually with the sun you stop eating. So सूर्य अस्त के बाद खाना नहीं चाहिए. दूसरा, eating according to ऋतु. So एक ही खाना हर ऋतु में नहीं चलेगा, हर सीज़न में नहीं चलेगा. तो ऋतु के हिसाब से खाना, अपनी प्रकृति के हिसाब से खाना. Do get your नाड़ी checked, तो आपको पता लगेगा कि आपका body constituent कैसा है, constituency कैसा है, आपकी प्रकृति क्या है, आपकी विकृति क्या है. So you can know कि आपके लिए क्या अच्छा है. But eating with the sun is my best advice.
Thank you. That's very true. Chrononutrition is very important and has a very important place now. Ma'am,
well, I don't believe that there is one silver bullet, like you said, for managing your health and well-being. But all I'd like to say is what matters is what you eat and how much you eat, how you eat it, when you eat it, and what you digest and what you don't eat. And also I like to add who you are. जैसे बात करें प्रकृति की, so सब चीज़ सबके लिए नहीं है. So who you are is also important. And I would just say that the kitchen is indeed your best pharmacy, and if the diet is right, then, no, if the diet is wrong, medicine will not work, and if the diet is right, medicine is not needed. So thank you.
Thank you all the panelists. I would just conclude here that, living a good, healthy, and a long life is actually not difficult. It is perhaps simplest of all. About diet, so many people have said, so I won't repeat that. Exercise is very important, already mentioned. The timings of meals are just as important because our body has its own clock, and it is best to work and eat in sync with that clock. The other important thing is sleep. So with diet, exercise, and sleep, if we follow these three things, we can avoid most of the disease, can have a long, happy, and healthy life. So thank you so much. Thank you, Rajput ji, for giving us this opportunity for this discussion. And thank you all for being here.
Thank you very much for an engaging discussion. Would request Mr. Anil Rajput, sir, to please join us on stage for the presentation of mementos. Can we all please give it up for our eminent and esteemed speakers? Thank you very much. We'll begin with the session moderator, Dr. Rajesh Keshri, sir, to please step forward. Kindly keep the applause going. Let's all take this opportunity to express our gratitude and thank them for sharing their valuable insights with us. Ms. Ishi Khosla to please step forward. Kindly keep the applause going. Thank you very much, ma'am. Dr. Shikha Sharma. Thank you very much. Dr. Shabana Parveen. Dr. Kalpana Bhamini Sehra. May I now request our esteemed speakers to please come forward and together for a group photograph. We once again thank our distinguished speakers for their gracious presence, for their time. Thank you very much, ladies and gentlemen. With this, we conclude today's insightful and impactful conference. Thank you all for your participation and support. And now we request you all to kindly proceed for lunch. Thank you very much. We wish you a great day ahead. Thank you.
Every life carries a dream. Every dream needs strength, and every strength begins with good health. Yet today, millions of Indians suffer from conditions that could have been prevented. Diabetes, heart disease, mental illness, conditions rooted not in faith,